Hi everyone that's already joined us. I'm just going to give everyone a few minutes to join. Wait until we've got everyone here. They're all popping in.
Hi, Ben.
I just noticed that too. Hi, Ben. Glad you could join us. Okay, I'll just give it a couple more minutes. We've got about 20 more people we're waiting for.
Yeah, we know we can't hear you, and that's a good thing, Ben.
So to everyone that's just has already joined us, we can't hear you, but you can type, and we can't see you, so you can do whatever you want in the comfort of your own home. There is a Q&A box on your screen. On my screen, it's at the bottom, so you can ask questions as we go through. Hi,
Morning, Caroline.
So we will try and answer questions as we go through. We've obviously got a Q&A session at the end as well. And if we don't get to your question, then we will address it maybe in the closed Facebook group that we've set up. So we will get to all your questions. Okay, I think we'll just give it a couple more minutes.
If anyone hears a gentle humming in the background, it's because my neighbours have very, very kindly decided to do their tree works today. So there's a couple of guys with chainsaws trying to distract everyone, but Zoom seems to be cutting them out mainly. Hi, Mark. And hi, the other Mark.
Kathy, hello Kathy. Glad you made it. Last minute, as always. We'll give it 2 more minutes because I think 5 minutes late is acceptable.
Hi, Jez. Hi, Tori. Hi, Jean. When I said hi, Jean, I meant hello, Jean, because otherwise that sounds like doing it.
Getting some last minute messages from Mr. Takar. We're getting lots of messages here now.
Hi, Helen. I'm not sure I'm looking that good.
So I think we'll get started. I think we've probably got almost everyone here. So just to repeat what I said at the beginning, you have got the chat, which you can use throughout, which we can see. You've also got a Q&A box. So on mine, I'm on a laptop, a PC. So on mine, it's at the bottom, but it may be different if you're on an iPad. It depends on your device. So if you want to ask any questions to any of the panelists throughout, you can. And you just type the question in and we can either answer that on text or it will be answered live, or we'll deal with it at the end in our Q&A session. So we should get to all your questions. Nothing will be forgotten. We're keeping an eye on those. this is obviously our first time online, so regarding internet connection and things, if things go a little bit glitchy, just hang on in there. It tends to settle down in my experience. So if your sound goes or anything, just give it a second. Hopefully it will come back. And thanks to everyone for joining us. So it's nice to see so many of you getting involved. I'm going to pass over to Layla now, because she's going to give us a little bit of information about planets. So over to you, Layla.
Okay. Thank you, Jo. No pressure, Layla. First on, having to work this. Right, I'm pressing share screen. I've got host disabled, attendee sheet, screen sharing. So Jo is just going to click that so I can go in.
There you go.
Thank you, Jo. Wonderful. Right, can you see that?
Yes.
Excellent. Hopefully everybody can see that. So yes, welcome to a very different Planets Neuroendocrine conference this year. And hopefully you've got all your lovely packs. Those of you that registered early enough that Jo has spent many hours collating and getting over to you. So you've hopefully all got your cup of tea and your chocolatey cookies and your face mask on or off, as the case may be. So fingers crossed, you're all ready. This is the plan for the day. We've got Mr. Pierce is going to give us a roundup in a moment, followed by Judith Cave, then Arjun, and then Zia. And we're going to have a quick coffee break, a little rest break, followed by Sachin, and then Ruth to do a little bit about dietary tips, which we all enjoy. And then we've got Andy Bates at 12:05 from Westfit. So hopefully everybody has got that schedule in front of them. And then we'll have Q&A at 12:25. There is no rush, so we've got plenty of time. But obviously, if you do have questions, please raise them, put your hand up, as Jo has said. So, what a year it's been. It's certainly not a year any of us have expected. And I certainly wasn't expecting to see this kind of photograph in my presentation for the NET conference, nor have I ever seen Southampton Hospital ever looking like that. So it's been a bit of a mad year, to say the least, with everything else going on. But luckily, we've been able to carry on services at the hospitals that we've got, which is Bournemouth, Portsmouth and Southampton, to the best ability, and feedback at the moment has been very good, and we certainly haven't any issues from patients that are missing out on treatments as such, and I'm sure Mr. Pierce will go into that later. We've managed to supply visors over the last few months, and you know, which obviously you can see the team wearing there at the bottom. And then just recently, we've as a little treat for what has been a horrific year for the medical staff at the hospitals, we've supplied the lovely caps that has been modelled by the gorgeous Mr. Stedman there in the right-hand corner. So anything really to help at the moment. The team's working really, really hard through this awful pandemic that's going on. As you all know, or for those of you that are regulars, those of you that are here today that aren't regulars, Planet started nearly 10 years ago now, and it was small fry, and we were just going to be a small little charity, raising money to get things like scanners and chairs refurbished in waiting rooms, and it's all grown way out of control, more than we ever expected, and we've raised over £1.1 million. Which is great. However, this year, I would have loved to expected to see all these sort of events going on. This year has literally had a real lack of fundraising, obviously for obvious reasons. We've had marathons and people do personal things that they can do independently, but unfortunately, the fundraising really, really has dropped dramatically, as it has for most charities across the country. So we realised obviously that our income was dropping quite dramatically. We still got a fair few letters and checks through generally, but the actual fundraising element, we were really dropping in funds. So we employed a PR company to help us set up a campaign in the second quarter of this year, and we set up an IORT campaign specifically to help us pay for the IORT machine, because that's an ongoing lease that we're paying at the moment. So we launched an appeal and it went on the BBC, and it really, really did well. And to date, we've raised over £60,000 for that. But we've also got contacts that are trying hard to help us raise some significant amounts of money. Nothing set in stone yet, but we're quite hopeful that these contacts that have expressed an interest in helping us over the next few months, hopefully they'll be able to help us further and get us out of the red, really. We also have applied for grants. We've employed a company to help us with the bid writing. They take a long time. They're very resource hungry. And Joe and I are really, really busy at the moment trying to run the charity as normal and keep everything afloat, and doing grants and kind of tenders, mini tenders really. It's really hard work. So we've employed somebody, and I would say we set up a contract with somebody that we chose, and within, I think it was 24 hours, he had applied and helped us apply for all sorts of different grants. So the first one that came in was a 10,000 grant from the lottery, and I'm now working directly with him on another 10, I think it is, over the next 3 months, which will hopefully help fund the income that we were expecting for these last few months. But certainly the 60,000 that we've already raised certainly does cover half of a year of fundraising. So that's good from a charity finance perspective. Next year, on the 30th of November, please put a date in your diary, because we will be celebrating our 10th anniversary. Can't quite believe that it will be 10 years next year, and I'm pleased it's not this year, obviously, because I think we all will need a good party next year. And so we've set this 13th of November as the day. It's our 10-year anniversary. It's going to be a big one. We don't do them small anyway, but it's going to be extra big this one. I'm going to pull out all the stops where I can. And so please put that note in your diary if you want to come along to that. The details will be going out at the beginning of January, hopefully when there is an end to this pandemic in sight. So Planet's vision, it's the same as it always was for the last year or two. The dedicated full-time dietitian, the IORT machine, the HIPEC machine, which we've got and is being used currently. We're looking for more R&D. Eventually, we would dearly like to employ a dedicated psychotherapist, and then we'd like to get more involved with fitness and the Westfit collaboration, and continually improve and develop the service across the country for pancreatic, liver, abdominal and neuroendocrine patients. So fingers crossed we can survive this slight blip that the pandemic is giving us, and carry on with this vision for next year and beyond. Joe and I have been working heavily in the background on setting up virtual events and things like this. This is the first one, but I think going forward, although the vaccines are out there, we've got 3 vaccines that are all looking to be, ready to be shipped within weeks at the moment, and I'm sure the other, there will be another 5 at least coming along. I don't think anybody believes that this is going to clear up very quickly. It's going to take a long time. So I think in future, a lot of our events will be virtually. If this works and we get good feedback, then we'll be doing that. And it's also to take care of the patients and make sure that we're not putting anybody else at risk that doesn't need to be at risk. We would like some more patient stories, because we're working on websites and building that up at the moment. So if any of you listening, certainly the new people that are coming along, and those of you that that have been along with us but never really sent us a patient story, then please, if you can send one along, that'd be great, because they really do help. I get phone calls pretty much every other day from new patients from across the board of the cancers that we deal with, and most of the time they always refer to a patient story they've read online, and that prompts them to give us a call. So that's really important. Had one yesterday for a colorectal patient, and completely on that basis. So if you can send us your patient stories, that would be fantastic. Also join the Facebook group. Joe has been setting up a Facebook group that kind of tries to cover the support groups that we haven't been having. And if you can join that, that's quite useful if you've got any queries. As always, you can call Joe or I, that's not a problem, or email us directly if you don't want to go public on the Facebook group. We're always here to help. Just a quick mention, we've got a new nurse at Southampton, and we've also got Mark over at Bournemouth has got an assistant, so it's just a quick hello to them, welcome on board. And I've got a bit of Rachel's background there. She's been 22 years in nursing, so hopefully she's on today and watching. Hello Rachel, and hopefully Mark's on today. Hello Mark, nice to see you. So fingers crossed, eventually we'll all get to meet these lovely new nurses and clinical staff in the flesh next year perhaps. Finally, as always, thank you for listening. Myself, Joe and the trustee board are working very hard to make sure that we have a plan, it's charity, that is robust and lasts the pandemic, and without you and without supporters and fundraisers we can't do what we do. So thank you for listening, and thank you very much for everything you do, and I will now pass you back to Joe.
So over to Neil now, who's just I'm gonna stop you sharing your screen, Layla.
Just shut off.
I think you might have to stop sharing your screen.
Yeah.
Okay. So we're passing over to Neil now, who's gonna take us through whatever he wants to.
Well, it's kind of whatever you want as well, really. I did have a few things to say, but Layla said them all. She always does that. It's
Sorry.
typical Layla. Anyway, no, as Layla said, it's been a really unusual year. It's been unusual for everybody. I've spent most of it at home. I'm at home today with the neighbours' workmen with chainsaws in the background. So if you hear an unusual buzzing, it's not my vibrator or anything like that. It is the gentleman felling trees in the background. Anyway, so it has been a strange year. Although I've spent most of my year at home, the teams in Bournemouth and Southampton and Portsmouth have still been working away at the coalface on the clinical side. And I'm pleased to report that actually our activity has barely dropped. If you look at us compared with many of the other trusts, particularly around London or the north of England and the Midlands, we have been really quite exceptional in maintaining our NHS cancer activity. One of the areas that's been more troublesome has been diagnostics, and that's partly because there's been slow referral pathways in, because a lot of people have been shielding, been staying at home, or just been too scared to bring themselves forward. So unfortunately, we are seeing a lot of late diagnosis of cancer, and that's across the board. But for everybody who gets onto the diagnostic pathway, we're processing them as fast as we can. And anybody who needs treatment, there are no delays to treatment from once we've got a diagnosis. And we expect that to continue all through the winter. Over this year, we've outsourced a lot of our work and done it at the private hospital at Spire. That's in the Southampton major liver pancreatic cancer work. We've always been able to do that kind of work at Spire. They've got a full intensive care, and we've just been able to keep going all the way through. Our work again is happening at the moment predominantly at the General, but there is still some going on at Spire, and that's going to carry on during December as well. But as we've got things so well organised, we're repatriating all of that work at present. So from January onwards, we're expecting all of our major cancer work to be done back on site at UHS. We did have a few months where we weren't able to use the Mobitron, the intraoperative radiotherapy, but that was at the peak of the pandemic in the first wave. But the hospital's so much better sorted than it was. We weren't sure what we were going to face, and at one point we had plans put in place for all the different eventualities, including mass graves on Southampton Common. So everything was considered, and for a while the hospital was run down to a point where it would only be a COVID-only hospital. At present, we've really got things very well sorted with our COVID pathways within the hospital, so that the patients that we've got are kept well away from all other clinical areas, and the infection risk and transmission risk is minimised. At the moment, we've got fewer than 50 patients with COVID in, and only about half a dozen on the intensive care. And that's a similar pattern in Portsmouth, Bournemouth, Poole, Salisbury. The Isle of Wight's got virtually none at the moment. So across the south, we continue to be relatively spared, but it's not getting away scot-free. It's still having an impact in terms of everybody's approach to work, how everything happens. All our interactions, all our meetings within the hospital are done on Zoom or Teams, more Teams than Zoom, to be honest. Just those little interactions that you have, everybody's 2 meters apart having lunch. It's face masks everywhere. The medics, those working over at Spire, are tested every week. Our patients, inpatients, are tested twice a week. That's just come back in. We're increasing the screening for all staff within the hospital. So, although it's been crazy and a really strange, surreal experience for everybody, whether you've been in the hospital or working from home, it has still been an effective hospital process. We've still been able to keep things going. And for those patients who are already on our books, I think it's hard to find any that have really been compromised. We did do a review of, I think, 270 patients, where question marks were raised about whether delays in treatment had led to any significant harm. And despite going through that with the consultants who have been looking after the various patients, we've not actually identified anybody who's come to significant harm. So our safety nets have been working, and whilst things haven't been perfect and things have been different, I think we've still been effective in delivering care, particularly for our cancer patients. I think the story is different if you're looking at people waiting for hip replacements and for benign conditions. There's a lot of big delays that have come into their pathways. And unfortunately, somebody's got to take it and take the brunt of the impact. But the important thing for us from a planet's perspective is that it's not the cancer patients. So if you've got friends out there who are saying, oh, I'm not going to go to my GP with this worrying symptom, tell them, get on with it, get seen, push to get scans, push to get whatever tests are needed, because things are still working effectively in the hospital. We have had the odd cluster of patients who've caught COVID within the hospital. Unfortunately, it's usually been in the most vulnerable groups, elderly care, and some patients on intensive chemo regimes, which has not been great. That was in the first wave, when we didn't really have all our processes quite as well sorted as we do now. With the second wave coming on, the in-hospital transmission rates are very, very low compared with what they were. So I think the hospital does remain a safe place. If you need treatment, then you're far better off getting treatment rather than sitting at home, letting things fester and get worse. Yeah, I think that's probably the main message. I did see one question about vaccines, which I'm sure is going to come up many, many times over. In general, I think the planet's patients will largely be safe to have any of the vaccines that come through. But one of the questions is, will it interact with Somatostatin or lanreotide? There won't be any interaction with any of the depot somatostatin analogues, so any of the octreotides, sandostatin, lanreotides. There'll be no interaction with them at all, and that won't be an issue. The only group that might have some considerations about timing of viruses is any of you that might be on chemotherapy, because any of those chemo agents do affect your immune system. So there might be some of the vaccines coming through that wouldn't be suitable for you. So, for instance, what we call a live vaccine, which has got a modified virus with some of the COVID proteins and so on stuck onto it, so that you get basically a very mild viral form of something that's similar to COVID in terms of the virus is similar for your body's immune system to recognize. Those kind of vaccines we usually avoid during chemo. So you could have it before, you could have it after, or more likely is you would be offered one of the other vaccines that are coming through. So there's a real range of vaccines that are being developed, and we expect to have a selection available over the next few months, and we'll be able to identify which one's most suitable for an individual. But for the majority of you, unless you're actually on chemo, I think if you're offered any vaccine, take it. Yeah. Any other questions?
I think that's all our questions that have come in so far. So next up is Judith Cave. So we're just going to bring her in. Here's Judith. Hi, Judith. So we'll pass over to you. I'm going to just make sure that you can share your screen, which I think you can.
I've got the green button.
Brilliant. Okay. Thank you. Passing over to you.
Thank you, Jo. Has that worked?
Yes, perfect.
Great. I don't know if I can see the questions. Will I be able to see them, Jo?
You should be able to see the questions. So at the bottom of your screen, there's a little Q&A box, and it will give a little red one if there's a question that pops in.
Okay. I don't have a box.
If you just hover your mouse at the bottom, does your bottom? It depends on the device.
Yeah, no, it doesn't.
Keep an eye on questions.
Will you let me know if any come through?
Yeah.
Thank you. Okay, My name's Judith Cave, and I'm one of the oncology consultants at Southampton General. So basically, I'm a chemotherapy doctor. I'm really honoured and grateful to be invited to talk to you all. It's been such a strange time for us, and I know Neil and Layla have already talked to this, but I really miss seeing my patients. I've been doing a lot of telephone work and a lot of video work, and it's really been very lonely, and so it's great to have an opportunity to interact with you all. Please consider putting questions in as I'm going through, if you can, because I've got half an hour and I don't want to be really boring, so hopefully if questions come in, it'll make it a little bit more lively, and Joe, you can let me know. So I'm going to talk about what are NETs and an overview of treatment. So hopefully this will be a good introduction to the rest of the conference. As we know, there are different types of NETs and different subgroups, so I'm going to cover that first. I'm going to talk a lot about how we plan treatment as an MDT, and then I'm going to go through briefly an overview of the different treatment options. It's hard to present an overview which isn't going to already tell quite a lot of people things that they know already. In fact, many of you are absolute experts in this area. So I'm really sorry if I'm telling you things you know already. Please bear with me. And as I said, please do type questions in the chat if you want more detail, or if I accidentally say anything that isn't clear. I've been doing a lot of teaching in this format over Zoom, and it is quite difficult to know sometimes whether you've said something clearly or not, because you can't see the faces of the audience. Maybe Joe, Layla and Neil, I can see your faces, so if I say anything weird, make a funny face. Okay, so here we go. What are NETs? So neuroendocrine tumours are tumours that start in neuroendocrine cells, and most develop slowly over several years. Just to do a tiny bit of jargon busting, again, this might be really obvious, but I just want to be completely crystal clear. So tumours, what we mean by a tumour is a lump of cells which is growing inappropriately and can spread or grow in new places. So these are the two features: uncontrolled or inappropriate growth, and the ability to spread and grow somewhere else. And we talk about them starting in neuroendocrine cells. So neuroendocrine cells are cells which are linked into your your messenger system in your body. They make hormones and release them to the bloodstream. And let's just talk a little bit more about these neuroendocrine cells. So most tumours are categorised according to the kind of cell they start in. And so when we call a lung tumour, it's because it started in a cell in the lung. Now, neuroendocrine tumours are different because they're not categorised by where the cell is, they're categorised by what the type of cell is. And neuroendocrine cells make hormones, not the kind of hormones you might normally think of when you talk about hormones, but hormones which control essential body processes like the flow of air into the lungs, the production of digestive juices, the muscles that move the food through the bowel. And because these neuroendocrine cells are in all different parts of our bodies, then it's much more complex to categorise the types of NETs. So we do categorise them according to the location of the cell of origin. So we say it's a neuroendocrine tumour because it started in a neuroendocrine cell, but where was that cell? So in the slide before, I'll just flick back, it might be in the lungs, or the liver, or the pancreas, or the stomach, or the large or small bowel. So we usually will categorise according to the location. Then we'll usually categorise according to any location of spread. Obviously, hopefully there might not be, but if it has spread to another location, we might mention that when we summarise. The next thing we categorise them by is this word called grade, which is a very difficult and it's a very important word for us, but maybe not always very clear what we mean by it. And essentially what grade means is how similar is the tumour cell to the normal neuroendocrine cell from which it was born. So if you consider the first cell, where the first cell that became tumorous, that will be like the mother cell. And then how similar are those daughter cells to that mother cell? And linked to this is whether the tumour produces hormones. So I told you that neuroendocrine cells produce hormones. So does the daughter tumour cell also produce hormones, and if so, which? So you might get a sentence that says, for example, grade 1 pancreatic NET with liver metastases, and that's a nice summary. And sometimes that will say in it functioning or non-functioning, meaning does it produce hormones or not. It's always important to mention the frequency of neuroendocrine tumours. So about 4,000 patients a year are diagnosed with neuroendocrine tumours in the UK. And we always think of them as rare tumours, but they are becoming more common. So on this slide here, the blue line is all types of tumours, and the red line is neuroendocrine tumours over time. And you can see from like the 1970s to the 2000s, the incidence is gradually going up. And so I think we're developing, as a medical team, we're developing a lot more expertise and knowledge about these tumours. So now what I want to talk about is a little bit about how we plan treatment. Is there any questions so far on the different types of NETs, or any? No questions? Layla's shaking her head. So what is different about NETs? And they are different. So some of these slides are the same slides I use when I'm teaching junior doctors or trainees about neuroendocrine tumours. And I try to make the point that these are different. They're more varied than other tumours. And because of the varied nature and because of the enormous differences between the experiences of different patients, what is most important is that we have a detailed assessment and a bespoke treatment plan. And I think it's tempting maybe for the medical world to see them as just another tumour, but for me, I don't feel like that. It's much more complicated. And I use this slide, again, when I teach the juniors, so I tell them there's much more to do than with other patients. So the first thing that's really, really essential for a neuroendocrine tumour patient when we're planning treatment is to consider the input from the MDT. So no single doctor should be making a treatment plan for a patient. We should always include the whole team. So nice picture of Mr. Takar here, who you'll be hearing from later. But it's complex disease. We need input from the entire team. And that includes the imaging. And many of you will have had this slightly frustrating experience of having had to have 3 or 4 or sometimes even more different types of scan before we know what's going on. And that is because the more we can understand about the tumour and what is turning it on or off and what is responding to, the better we can plan the treatment. And the more we can know exactly where it is, the better we can plan the treatment. And some of these different types of scans give us layers of more information about it. So the next thing is the urinary 5-HIA. And again, this picture will be familiar to many of you, and I'm sure not particularly welcome. I'm very familiar with the situation where I give one of these bottles to people and their face falls. But it really does help us to know whether the tumour is producing hormones, and if so, which. So the urinary tests give us an accurate detail about the amount of hormone being produced, which can be useful for monitoring treatment. We do also blood tests called chromogranin A or B, and that is a similar thing. And sometimes we do the fasting gut hormones, where you have to have a blood test before breakfast, and that can tell us if the tumour is overproducing any of the gut hormones. And sometimes the history can be just as important and I always try and teach my junior staff to take a really careful history from the patient and ask about symptoms of carcinoid syndrome. I'm going to talk a little bit more about what we mean by this word in a moment, but it can be very subtle, and sometimes a patient can notice long before we find anything in the blood test. So it's really important to talk to the patients and ask them. That's what I say. I also mentioned the importance of the past or family history, which many of you will have been asked these questions multiple times. And when we're planning treatment, all of these factors are important. So we use this word functioning, and as I said, some of you will have been told you have a functioning or non-functioning tumour. What do we exactly mean by that? So carcinoid syndrome is caused by hormones the tumour produces, and the symptoms of that can be very variable, but flushing and diarrhea are common. Weight loss and abdominal pain are, I think, also common, but sometimes maybe not so much focused on. Some patients will experience even feeling faint or collapsing when they have a bad episode of carcinoid. And in rare cases, there are more worrying symptoms such as low blood sugars. And sometimes the type of syndrome that you might have might depend where the neuroendocrine tumour started. And this will be about that mother cell. What kind of cell was that mother cell? Was it in the small bowel, in which case we often get the classical carcinoid with flushing and diarrhea? Or was it maybe in the pancreas, which can cause a wider variety of hormone symptoms, including low or high blood sugar, excess stomach acid, etc. And when we work together, the first thing we should do is try to control carcinoid syndrome if possible. And that's because sometimes the actual carcinoid syndrome can be the main risk for a patient. It can be unpleasant, but it can also cause heart disease and weight loss. And I think, again, it can be sometimes confusing to understand why your doctors might be so worried about scanning your heart or talking about your heart. But for us, it's a real risk and a real long-term risk. So we try our very best to control the carcinoid syndrome. And that's because the circulating hormones that are in a too high level can cause scarring on the heart valves. So many of you will have had a heart scan or a blood test to scan your heart. And these are very useful for us to see if there's any potential for future risk there. So how do we control the carcinoid syndrome? So we can use drugs, and I'm going to talk a little bit about somatostatin analogues in a minute, or we can just try to destroy or remove the tumour, because the less bulk of tumour there is, the less amount of hormones will be produced. So sometimes even if you can't take away all of the tumours, sometimes just reducing the amount or the bulk or the number will help with the carcinoid syndrome, and that can be really beneficial. Sometimes it's important to get specialists involved at this stage. For example, a specialist endocrinologist who's a hormone doctor, or a specialist gastroenterologist who's a stomach doctor. So let's just talk about this concept of a somatostatin analogue. So the next few slides have got a little bit of science in them to try and explain what this is and what it does. So usually our guts are controlled by hormones. So when we eat a plate of food, a message sent from our stomach to these neuroendocrine cells, they produce hormones which help our guts work the food through at the right speed so that we absorb all the goodness and we can grow. So this is normal physiology. And when we've finished eating, a similar process occurs to turn off those hormones and to down-regulate them, so the gut stops moving along. And your gut's like a conveyor belt from your mouth to your bottom end, and you want it to go at the right speed, basically. Obviously, the problem with neuroendocrine tumours is they produce these hormones randomly, and then sometimes the conveyor belt goes too fast and you have diarrhea. And sometimes, worse than diarrhea, you have failure to absorb the goodness from the food, which can cause weight loss. Have we got a question, Jo? No. So I think I might have just found how to look at the, oh yeah, no questions. I found how to find the Q&A box, it appeared. So the problem with neuroendocrine tumours is they produce these hormones randomly, not according to any regulation, just randomly. Somatostatin is one of the hormones in your body, which is effectively, I've called it the empty plate hormone. So what it does is it says, like, stop moving, the dinner's over, you can relax now, and it tells the gut to stop processing, to slow the conveyor belt. So these 5 green buttons here are the receptors. They're a picture to represent the receptors on neuroendocrine cells, which the somatostatin, the empty plate hormone, that can activate. So in other words, the buttons that are pressed by your body when you've finished eating and your gut should relax and stop. And you can see that actually it's not just one type of receptor, there are 5 different types of somatostatin receptors. So this somatostatin is a really useful hormone because it can slow the gut down and stop diarrhea and stop carcinoid syndrome. And we have different ways of artificially pressing those buttons, and octreotide is the commonest one that you'll many of you will have already been treated with this, either sandostatin or lanreotide. So that is a synthetic version of your body's own empty plate hormone. And there is a newer drug called passeriotide, which some of you may have been offered or taken, which does a very similar thing, which covers a slightly wider range of these buttons. But you can see from this diagram that our drugs are not as perfect as the human body. So the human body can activate all the receptors, but the drugs we have at our disposal at the moment cannot activate all of them. So the onus is on us as a medical community to do more research into this area and to find better drugs for the future. I'm going to move on now to talk a little bit about some of the treatment options, unless there are any questions before I move on. No. Joe, I didn't hear you. No.
None showing at the moment.
Okay. So what are the different treatment options that we can use? So I suppose, first of all, it's important to say, what is the goal of treatment? So obviously, the option we choose will depend on what our goal is. And there are really two main goals. First of all, if possible, to cure a tumour so it never comes back. And that's like the holy grail, the thing you're always searching for. For some times, if a cure is not possible, then the goal will be to prolong life and control symptoms. And a lot of what I do is the second goal, and it's, I would say, absolutely just as important and requires the same focus and attention to detail. So we'll always consider surgery or ablation first, and we'll ask ourselves, is it possible to remove or destroy this tumour and hence potentially cure it? And this is where the input from the MDT is extremely important, because sometimes with a neuroendocrine tumour there could be more options for surgery or ablation than there might be for other types of tumour. So we've included this morning a detailed talk about surgery and when this should be considered. So I'm not going to cover that in detail now, because Arjun's going to talk about it later. If surgery is not possible, then we would consider what we call systemic treatment. So systemic treatment means treatment to the whole body, because we can't just focus on where the tumour is. And there might be a number of reasons why we might do that. It might be because of the location of the tumour, it's not possible to remove it or ablate it, or it might be because of patient factors, so the patient might not want to have an operation. I've got a question. So someone says, should everyone with NETs be having treatment for carcinoid syndrome? And that is a good question. So just to be absolutely clear, if there is carcinoid syndrome, then attention should be made to treating it. Not all patients will have carcinoid syndrome, so not all patients will have a functioning tumour. If the tumour is not functioning, then you don't need treatment. I'm going to discuss some of the other reasons we use somatostatin analogues in a moment. And I'm going to just shut this box so I can see the slides. Okay, so systemic treatment is to be used when surgery or ablation is not possible. And these are treatments which go to the whole body. And here I've put the 4 main categories of treatment. And the first one is somatostatin analogues. So I've already explained to you what sometimes we use somatostatin analogues to control symptoms, but we sometimes also use somatostatin analogues to slow down the tumour's progression or growth. And that is because effectively those little green buttons I showed you, the 5 receptors, they're basically off buttons for these cells. So sometimes we find if we can use a synthetic somatostatin to press the tumour's off buttons, it will actually slow down or grow slower. It usually won't shrink or die, but it would usually slow down or grow slower, which obviously is a good thing. So somatostatin analogues can be used either to control symptoms or to slow the tumour down. That's the first one. When it comes to choosing between these different treatment options, It's a very detailed matter. And of course, it does include a discussion with the patient. And sometimes you might find that your doctor might say to you, these are the options. And that then you can think about the pros and cons of each. But hopefully this overview will give you some idea of each of them. So the second kind of treatment we sometimes use that I'm going to address is what we call chemotherapy. And I think sometimes this word sort of strikes a little bit of fear into people's hearts. I use a lot of chemotherapy, and it's not one thing. So different chemo drugs are different, and different patients' experiences are different. But the kind of, I'm going to try to give you some of the overlying principles around chemotherapy. And I would also say that if as a patient you're being offered this or considering it, just be mindful that as Jo said at the beginning, that different people have different stories. Some people will tell their chemo stories, and it might be different to someone else's chemo story. So chemo is a very variable thing. The most common way we give it is by drip. So this is a lady sitting having a drip, and it just looks like a bag of water when we give chemo. It has these rather alarming yellow labels on it, but essentially it just looks like a bag of water, and it goes into your arm. And the word chemotherapy is used to mean drugs which kill dividing cells. And I already explained to you that really what a tumour is just cells that are dividing more than they should be. So in order for a lump to grow, one cell has to grow into 2 cells, into 4 cells, into 8 cells, etc. So if we can kill a cell at the point at which it divides, then that is a way of targeting the tumour. So I just want to explain a little bit about how it does this, because I find the science really fascinating, but I'll try not to go on about it too much. So in your cells you have DNA, which is the code. It tells the cell the code to make a new cell. And when a cell wants to divide, it has to copy all of the DNA in it, which is a really big, complicated process. And in order to copy the DNA is like spaghetti, is all wound up in the middle of the cell. And in order to copy it, it has to unwind it, and then it has to make a like-for-like replica. And when it makes the like-for-like replica, there are 2 strands to the DNA, and it has to get them all sort of laid out flat. And some of the commonest chemotherapy drugs, all they really do is they just tie the 2 sides together like that in a knot. And when the cell gets to this knot, it won't be able to copy it because it won't recognize this big chemotherapy molecule that's in there. And it'll say, well, I can't copy that. So what I'll do is I'll just take a little break and start again on the other side. And what that means is that the daughter cell that is made in the presence of the chemo will have what is called a double strand break. And most cells have an internal mechanism which says, if I have a double strand break, I'm damaged and I should die, I should kill myself. So the cell actually kills itself. The chemotherapy inflicts the damage, and then the cell kills itself. So that is one of the many complex ways how chemotherapy kills a dividing cell. And you might say to me, and you would be right, this is like a spreading weed killer on the whole garden, and it kind of is. You know, it's a very non-finessed approach. You're basically rounding up. So any cell which is dividing in your body, when you receive a dose of chemotherapy, will receive a similar damage. But the really beautiful thing is that your normal cells that have the proper processes in place will be able to recover better than the tumour cells, and that is usually why chemotherapy works. Of course, the problem is that sometimes the tumour cells, they get smart and they figure out a way around it, and we call this resistance. So it doesn't always work, and it doesn't always work forever, but usually it's a good approach. You might say, well, rather than spreading the weed killer on the whole garden, is there something more intelligent we could do? And sometimes we do use chemotherapy injected into the hepatic artery, and some of you might have had this. It's called TACE. Sometimes we do inject chemo in other types of tumours into other places. We also have some drugs, and some of you might have had capecitabine, which are really smart ways of delivering the chemo specifically to one location. So capecitabine selectively delivers chemotherapy into the liver. But as you know, probably if you're a gardener, this is not a hugely always a successful approach. I don't know if anyone's done this, but I tried it with my dandelions, didn't work very well. So it doesn't, the problem with chemo is it can work really well, but it doesn't always work. So we've covered somatostatin analogues and we've covered chemotherapy. Two more options I want to just cover. Targeted treatment, tablets, and targeted radiotherapy. So targeted treatments, the goal of these is to be a little bit smarter than the weed killer to the whole garden approach, and to try to understand what is it about this cell that's growing that is different from the other cells. Why is it growing? And we know that neuroendocrine tumours are highly dependent on a rich supply of blood vessels. We know from looking at them down in the imaging that they have these millions of new blood vessels. So there are some tablets we use, sunitinib is the best example, which basically stops the body from making new blood vessels. We also know that often neuroendocrine tumours have defective genes in their internal growth control mechanism, and that we can target those defective genes. So everolimus is an example of a drug which will do that. So it will essentially get inside the cell, find the bit which is broken, which is saying keep growing, and then block it. The advantages of targeted treatments is they tend to be tablets, not injections, so they tend to have less side effects, although they still do have some side effects. It's also a really smart idea, and sometimes they can control disease for long periods of time. So sometimes I have patients who can take a tablet for many, many years and it keeps their tumour under control. The disadvantage is they do still have some side effects, and they're not funded for all types. They're expensive, and so we have to apply for funding, and we're not always successful. Of course, they don't always work, and they don't tend to shrink the tumours, they tend to stabilise them. So the last treatment option that I want to mention is about targeted radiotherapy, also called PRRT. And I showed you before these buttons and how we can press them with the synthetic somatostatin. So essentially PRRT is that same drug, but with radioactive compound attached to it. So it carries the radiation to the tumour and destroys it. And you're going to have a whole talk on this later, so I'm going to just mention it and move on. I think it's really important. I've said these treatments, they don't always work. So from my perspective, it's key that we constantly monitor. Is it working? Is it still working? Keep monitoring. Monitor by symptoms, monitor by the blood tests or the urine tests, and monitor by the scans. Obviously, you need to know where you were before you started in order to know from a second scan whether it's working. So I do, unfortunately, have to ask my patients to have a lot of scans, and it's important. So I'm going to just summarise, and then hopefully, if you do have any questions, answer them. So neuroendocrine tumours arise from neuroendocrine cells. We need a bespoke treatment plan. It's essential that we do a thorough assessment before making the plan. It's essential that we involve the MDT, the multidisciplinary team, and we've got a wide range of options nowadays, thankfully, including somatostatin analogues, surgery, ablation, chemo, tablets, and radiotherapy. Thanks very much.
So Judith, if you just stop sharing your screen. Thank you. Okay.
Has that worked?
Yeah, that's great. So has anyone got any questions before we move on? We haven't had any pop up. If you do think of something, we can come back to them at the end, because we've got the Q&A session, and I'm sure Neil will be able to answer if Judith's not around anymore. Okay, so next up is Mr. Takar. So I'm just bringing him into the room. Oh, we have got a question now, actually. So Judith, can you see that?
Yes. It says, I've heard a lot about contraceptives affecting nets. Is this your area of expertise? To explain how? I do not think that is my area of expertise. It's certainly not something that I have personally had experience of amongst my patient group. In fact, I have found there's not been a problem. So I would say that if you're worried about something like that, you should talk to your treating clinician, but probably it's not a major concern. Then I have a second question which says, what determines octreotide versus pasireotide? And this is an excellent question. So octreotide is well established with many years of experience, and also we know with octreotide that it slows the growth, or can slow the growth in some groups of patients. So octreotide is much more well established, and pasireotide is newer. And it is not generally available. So we've been able to get some supplies for some patients on what's called a compassionate use program, where we approach the company that makes it and ask them for a supply, but we're not able to prescribe it freely, and that is because we don't have evidence that it affects the actual disease, only the symptoms. I hope that answers your question, but please let us know if not.
Okay, so thanks, Judith. Thank you so much. We're moving over to Mr. Takar now, who I can see is live. So you should be able to share your screen, hopefully, but let me know if there's any issues. Here we go. You are on mute.
Can you see that now? Sorry. the typical Zoom sort of disasters. You can. Excellent. Okay. Well, hello everybody. I'm Arjun Taka. I'm one of the consultant surgeons at Southampton General. I'm actually in the middle of a case, so I've just come out whilst a colleague has taken over whilst they are continuing. Not a neuroendocrine case, I might add. But I'm going to talk to you about the surgical perspective for the management of abdominal neuroendocrine tumours. And actually, having sat through some of Judith's talk, I think the theme is going to be the same across most of the day, that treatments are bespoke, every patient is completely different, and that conversation is one that you have to have with your sort of clinician teams that are looking after you, because in truth, although we talk about specific aspects of neuroendocrine tumor management, which can, in this case, include surgery, chemotherapy, drugs, PRRT, radiology, the truth is most of our patients and a lot of our long-term patients will have had some form of those individual therapies across the course of their treatment. So it is, I suspect, will be a day of sort of a repetition of themes, really. So just very quickly, I'll see if I can go through things. I think there's been a lot of conversation in the previous presentations in terms of what are nets, etc. I'll touch on them very briefly and then talk to you about how it pertains to surgery. But I'll also go through a case which will hopefully be a good demonstration of the fact that although I will again talk to you specifically about the technique of what we think about when we are going to do an operation for neuroendocrine disease. In truth, patients will go on and have a whole combination of treatments. So let's just very quickly talk to you about what neuroendocrine tumors are. And as Neil and Judith would have said, these are tumors specifically that arise in the body in neuroendocrine tissue, which is found in specific areas, but also specifically in organs. And normally, the diagnosis is made after a considerable length of time. Mostly, the symptoms that patients get tend to be non-specific. They tend to be on and off abdominal pain, change in bowel habit. Sometimes patients will complain of fatigue. Frequently, I'm sure a lot of people in the audience will know that they get labeled as IBS for many, many years. And actually, they'll have a scan for something entirely different when their neuroendocrine tumor and potentially advanced neuroendocrine tumor, especially in the abdomen, will be then sort of diagnosed, and it all falls into place. We're not going to talk about lung nets, but again, there is a specific set of symptoms which includes wheezing, sort of shortness of breath, which can be sort of associated with those. The diagnosis, well, like we said, a lot of the time, the patients will have actually been told that they have IBS and will then grumble along with symptoms for many years. And I think I have a slide here which basically tells you that the time span between, if you actually take a detailed history from a patient once the diagnosis has been established, tends to be on average around 8 to 9 years. So it's a considerable length of time for when a patient has been labeled as neuroendocrine tumor till the time they get a diagnosis. And that's precisely because the symptoms are so non-specific that actually they could be attributed to pretty much anything. But like we said, you could, of course, have, for a non-functioning, you have non-specific symptoms, and then those are the patients who have got the carcinoid syndrome will know that actually for many years they'll have had flushing, abdominal pain, some watery diarrhea, sometimes shortness of breath, which will go with the typical carcinoid syndrome. Also, that's what the patient is telling you, but also if you see you see an abnormality in a scan or on endoscopy, so that's a camera test down, sort of the gullet or up the bottom end, you take a biopsy, you will then confirm the diagnosis by a variety of specific stains, etc., which will show you under the microscope that this is typical appearance for a neuroendocrine tumor. You can also do some blood tests, and quite a lot of our patients who are in on this meeting will know that they get yearly or 6-monthly chromogranin tests, but also 24-hour urine collection for urinary 5-HIAA, which is hydroxyindole acetic acid. You don't need to know that, but it is a good marker for metastatic or secondary cancers in the liver, because they specifically produce this substance, which can then be shown in the urine and will, across time, give you an idea of how well the disease is being controlled. But also, those of you who have specific neuroendocrine tumors, which are effectively secreting hormones such as insulin or gastrin, we will look at those across time to see what's happening with the disease, but also once we've operated on a patient and removed the tumor that is making this abnormal hormone, then actually if you can't detect it anymore, then there is a good chance that they have been cured. And of course, all of that needs to be then joined up with imaging. And again, hopefully there'll be more detailed talk in the radiology session about sort of CT scanning, so CAT scanning. That's the basic thing we use in terms of diagnosing and staging the condition. MRI scanning, which is very good for looking at the liver. Endoscopic ultrasonography, so it's EUS. So this is a camera or an endoscope that is put down the mouth, through the gullet, into the stomach, especially helpful in looking at tumors in the pancreas. There's a scanner at the end of the endoscope that allows us to lay the scope alongside the wall of the stomach and effectively scan the pancreas. But also, once we've found sort of abnormalities on the scan, we can take a sample and prove that this is indeed a neuroendocrine tumor. And then, of course, standard endoscopy. So the so-called top and tail. So a camera down the top end, a camera down the bottom end. Not the same camera, I might add, but allowing you to take a biopsy and confirm that diagnosis. And again, those of you who've been through this, unfortunately, will know that this is a process that takes a considerable length of time. So not only does it take a long time to come up with the diagnosis that you have neuroendocrine disease, but also then to get the tests. And you will know, or a lot of you will know, that the blood tests take about 2 to 4 weeks to come back. In the old days, they used to have to go to London. They now are done locally, but they still take some time. You have to go to specific places to have scans, and I'll talk about nuclear medicine imaging, which again, I think Zia has already touched upon, whereby we know that neuroendocrine tumors will express the so-called somatostatin, sort of receptor, so octreotide receptors. They're the same thing. The term is interchangeable. So the tumor has these studied across it, and you can then give patients a specific drug which will go and sit on the tumor if it is active, and then light up on specific scans. And these are the octreotide scans in the old days, tetrachoid scans now, but also increasingly moving on to the gallium PET scan, which is at the moment done in London, but hopefully in the not too distant future will be done locally, which gives us a very good idea of of the extent of the disease. And again, in terms of what Zia might have explained and what Judith was saying, would qualify the patient for PRRT treatment. So a good example here of two combinations of treatments. So this is a relatively young patient who's been diagnosed with a tumor of the pancreatic body, and by that I mean, just very quickly to just go through, if you can see see my sort of mouse pointer, this is an abdominal CAT scan of a patient. This is the one on the left, and what we're looking at here is we've cut across the patient. So what I explain to patients is that this is as though we've cut across, and if you were that patient, then your head is behind the screen, your feet are towards me, and we're looking up the body. So basically, that's the right side there, that's the left side on that side, and we can look at specific levels in the body to see specific organs. So, for example, this is the liver here on the patient's right side. That's the beginnings of the gallbladder. Kidneys are here. That's the spleen on the left side, and then in my red circle there is a abnormality. If you look, that's the normal pancreas there, and then you can see a bulge there, which is very, very suspicious for what we think is potentially a neuroendocrine tumor of the pancreatic body. And this patient has then gone on and had a tetrachoid scan. And if you look over here, there is a bright spot on the right side now. So this is the sort of image on the right side, which is effectively confirming the diagnosis. And this patient required an operation to remove the end of the pancreas, so what we call is a distal pancreatectomy and splenectomy. The reason for the splenectomy, we get asked this all the time, is that the glands or the lymph nodes where tumor cells can go and sit, which can determine whether there is a possibility of recurrence that will happen in the future, all sit with right at the end here in what we call is the splenic hilum. So so to sort of allow us to do what we call is the best possible cancer operation, we do need to take the spleen, but also the blood supply, which is that to the spleen, runs through exactly where we want to do the operation. So there are two reasons for why the spleen sort of effectively hits the bucket as part of the operation. This is another example. So this is in the front or the head of the pancreas. So this is quite a large tumor in the pancreatic head. This patient had a Whipple's procedure not that long ago, in fact, about 3 years ago. The good thing about a neuroendocrine tumor is that it allows you to be quite aggressive. If we had looked at this in sort of so-called, in inverted commas, I might add, standard pancreas cancer, because it is touching quite a lot of important blood vessels. In the standard pancreas cancer world, we would be thinking that this is potentially inoperable, but also that this patient might need chemotherapy to shrink the tumor down effectively beforehand, before we do the operation. But in this case, we could do it quite safely. The patient, in fact, did very well. They had a sort of Whipple's procedure. So this is the big operation where we take away the head of the pancreas, but also the bile duct, which is the tube that connects the liver to the bowel. Also, the whole of the duodenum, which is the first part of the small bowel, and the end of the stomach. And then we plug everything back up again. So it's a complex procedure. We thankfully have a very good track record of these, but this particular patient went home in just under 8 days and has been well ever since. So there are lots of possibilities that lots of combinations of things that we can do. So we've talked about diagnosis, and like I said, 9.2 years is the average, the so-called average between when a patient has these non-specific symptoms and when they get diagnosed. So I'm going to talk about treatments, but then I'm just going to sort of, I guess, interject with what this means in terms of surgery. So just both bits, which I'll sort of come up with, and the reason for that is that, in truth, there isn't a specific combination that all patients with NETs end up, sort of getting, and that is the bit, I guess, that we try very hard to explain to our patients, that having had one treatment and completed it does not, unfortunately, mean in a lot of people that that's the end of it. And with neuroendocrine disease, we do tell patients that you need to probably get your head around from what you hear about in cancer treatment, that, look, I've had the operation, now I'm potentially cured. Actually, there's a lot of patients that we can do that for, But in truth, especially patients who are diagnosed late and have secondary cancers, sort of elsewhere. So for example, if they've got a small bowel neuroendocrine tumor with secondary cancers in the liver, or a pancreatic NET with secondary cancers in the liver or elsewhere, then in actual fact, an operation is a part of the bigger strategy. The other thing that we try very hard to sort of explain to our patients is that, again, if they read about standard cancer where they hear that they have a primary cancer in the bowel or in the pancreas with secondaries in the liver, then if you read the normal press, that generally tends to mean quite bad news. And in truth, this is not the same as the so-called standard cancer, because even though quite a lot of our patients will have secondary disease elsewhere from the site where the original cancer was, we can actually keep the disease under control, and long-term survival is measured in many years. So I'm sure Neil would have explained, we actually have patients who had their sort of original operations in 2005 who are still coming to clinic in 2020, are quite well and have a good quality of life, still have disease, but are still getting some forms of the treatments mentioned here. So very briefly, surgery, so with a potential to cure, and actually if you have the disease which is just confined to that particular sort of organ with no secondaries elsewhere, then that is a distinct possibility. But also quite a lot of these patients, if they have symptoms, will go on to long-term octreotide or lanreotide or pasireotide, so that is for symptom control, but we also know that that has a potential anti-cancer effect. If there are secondaries in the liver, we can do sort of treatments on the liver, which include ablation and embolization, and in most extreme cases, transplantation, although that is not really taken off in the UK, and we're not entirely convinced that is the right way to go. But also treatments such as drugs, which hopefully, has been mentioned by Judith, and chemotherapy and other treatments that are now coming onto the market, and also PRRT. So in actual fact, trying to, I guess, explain to newly diagnosed patients that this potential diagnosis, which is of course extremely devastating, does not necessarily have to mean, one of the first things I say to patients when they come to me or come to our, sort of clinics, and we're talking about an operation, but they've also got secondary cancers, the first thing I say, I guess after sort of introducing myself, is that, look, I'm just going to tell you this now. You're not really going anywhere for quite a few years to come. You just need to understand that. You need to just be clear that this is not something that is going to potentially, kill you in the next few weeks or months. In some patients who have very advanced disease, potentially yes, but in quite a lot of patients, that we do need to make it quite clear to them, and I tend to do that in the start of the consultation. Then we can talk about a stepwise approach to how we're going to go about treating them. So this is the same theme, I guess, is this concept of cure. And again, I have to say, try and steer our patients away from, especially if they have secondary disease, to steer them away from the concept of cure, because I do say you're going to be coming to this clinic for pretty much most of your life, but the truth is we can keep you going with a good quality of life for a very long time. So our treatment emphasis is actually based on disease control and quality of life. And of course, as I said, an operation would play a role along with other treatments. So just very quickly, it's quite a busy slide, but I will try and sort of explain this. Now, so obviously, when we have someone who's come in with a diagnosis of a neuroendocrine tumor, be it in the pancreas or in the bowel, we would look at their age and fitness, but also look at the grade of the cancer. So the so-called Ki-67 index, which is basically telling us how fast the tumor is growing. Now, if the tumor is confined to that particular, sort of organ, so we're talking pancreas, liver, pancreas, small bowel, large bowel, and actually it is just confined to that particular place, then in truth, there is a very good chance that we can potentially offer you a cure. If you have metastatic disease, and as quite a lot of the patients in this group will know, that they have only been diagnosed because they've been found to have secondaries in the liver, and then we find out that they have a primary cancer in the pancreas or in the gut. Well, in that case, we can do an operation, but the emphasis becomes a bit different. This is mainly to do with disease control, and what we call is debulking or cytoreducing the actual disease. Now, the reason for that is I like to think of it in a simplistic manner, that if there's as little disease left behind after doing the operation, then especially for the gut-related tumors, then there's a less chance of there being an issue with things like gut obstruction in the future, but also there's less tumor for other treatments to have a role to play. Again, we also know that if you have bad liver secondaries, then sometimes the carcinoid syndrome can be quite severe. And actually, we do quite a lot of operating to effectively remove those tumors without touching the primary cancer, especially if it's not causing a problem, to make the patient's symptoms better. And we've got hopefully a few patients in the group today who've had that done. And of course, there are some patients who we leave well alone for lots of reasons, but they could potentially include age and fitness, and especially in the very slow-growing tumors. If you're diagnosed with metastatic neuroendocrine tumor at the age of 88, there are chances, especially if it's a low-grade one, that is probably not what is going to kill you. It could be simple, I guess simple other things like heart disease, all those other things that can come with age. So the options in terms of treatment tend to be, so by sort of SSA, we mean somatostatin analogues, and this is the long-term octreotide and lanreotide injections. Obviously, an operation to sort of remove the cancer and potentially cure, but also to debulk. And also, I guess Sachin Modi is going to talk to you about what we call is radiologically downstaging the disease. So sort of attacking the sort of disease mainly in the liver to ensure that the tumors there aren't active and can shrink down. But also, as Judith mentioned, you can have molecular targeted therapies such as sunitinib and everolimus, but systemic chemotherapy. So that's standard chemotherapy, so particularly for these cancers, especially the high-grade ones, and PRRT, which is the peptide receptor radioisotope treatment, which Zia might have mentioned. But the truth is, you will have patients who will have all of those treatments across their lifetime, or a combination of those. And that's the key to sort of remember in terms of treatment for neuroendocrine disease. So a good case study, this particular patient may well be in the crowd today. 50-year-old lady who had presented to her GP with vague symptoms. Again, sort of like I said, they'd had symptoms for quite some time, could have been misdiagnosed as IBS. Sort of ultimately went on to have a CT colonoscopy because they couldn't really tolerate the normal colonoscopy. So this is a CT scan which looks at the large bowel, and that's when they picked up a mass or an abnormality in the bit of the gut from the small bowel where the blood supply comes through. And actually, when we talked to this lady, it appeared that they'd had a dicky tummy or a funny tummy for quite a few years, like I sort of mentioned before. So they went on and had a whole spectrum of investigations, which included a CT scan, a sort of liver MRI scan, a tetrachroid scan, the blood workup, as I'm sure a lot of you know about, liver biopsy, which showed that this was a grade 1 NET with quite a low growth rate. So the key 67 of less than 1%, and they were started on long-term octreotide as a first step. But then we thought about doing an operation to try and maximally debulk their disease. And again, just to show you, this is what the CT scan picked up, which is a node, so lymph node metastases in the bit called the mesentery, which is where the blood supply to the small bowel comes from, and that's the bit that picked up the abnormality. And then they went on and had a sort of MRI of the liver, and you can see there are some sort of secondary cancers dotted here, and these were across the liver. And they had a tetrachroid scan which lights up, which shows that they have a tetrachroid avid nodal mass, so that'll almost certainly clinch the diagnosis of a neuroendocrine tumor, but also that they had bone metastases, so bone secondaries. Again, if you looked at this in isolation and didn't know much about neuroendocrine tumors, you'd think, oh my goodness, this is really, really awful news because this is quite advanced disease. Now, undoubtedly, this is advanced disease. But again, my first conversation with the lady was that you would have disease, but this does not mean that this is the end. This means that we are we are going to be keeping an eye on you for quite some time, but we would also be doing lots of treatments to keep the disease under control. So it's just that mindset, and I completely understand that when patients get diagnosed and get told in hospitals where they don't treat these conditions on a regular basis that they have advanced cancer, it becomes quite a difficult conversation. So a lot of my clinic time is spent trying to tell patients and reassure them that I think that they'll be around for a while, and unfortunately for them, they'll be seeing us on a regular basis for quite some time. So this is what we found. So this is the tumor. So that's exactly that, that abnormality that I showed you on the scan. So that's the thing that showed up on the CT scan and then lit up on the tetrachroid scan. So this is a lymph node metastases in the mesentery of the small bowel. So this is where all the blood supply of the bowel is going. And we've marked the extent of one of the tumors. But in fact, if I show you the slide, 15 sort of secondary cancers that we removed from the liver, 5 tumors taken out from the small bowel. Also, the lining of the abdominal cavity contained some disease which we had removed. And actually, at the end of the day, which is a long day for both patient and the surgeon, we could happily say to them that we had removed all their visible disease. 8 months later, they had a gallium-68 scan in London, which showed some disease that was left behind. Here is the bone disease that's become quite obvious. But actually, they are going off to have PRRT treatment. So we would treat all those sites of disease that were left behind. And actually, you would think, and our sort of expectation is that they would be coming back to our clinic for regular follow-up for quite a few years to come yet. So in conclusion, the treatment for JEP-NETs is what we call them, is abdominal tumors. So of the gut and of the pancreas require a multidisciplinary approach because the patterns of disease tend to be quite different for each and every patient. So as Judith said, it is a bespoke approach. We do tailor the sequence of events, the sort of sequence of treatments based on every patient. And sort of, like I said, you could have pretty much every single treatment mentioned across the talks today, across a few years to keep the disease under control. So, and by that, sort of I mean having an operation, having, sort of embolization, treatment with the long-term injections, targeted therapy, PRRT. I'd like to just acknowledge a few people. I work for the Wessex Net Group, which Neil founded. And then my colleague Tom Armstrong runs now. The great thing about us doing treatments in this part of the world is that it is truly a collaborative effort. We have clinicians that work across 3 sites, across Portsmouth, Southampton, and Bournemouth and Poole, and we all talk to each other at the weekly Neuroendocrine MDT. And we do joint clinics. And I have to say, it's one of the highlights of my working week. I'm happy to take some questions.
So Arjun, I don't know if you can see, there is a question.
I can. Yeah. Okay, so we've got a question here saying maybe a question for Q&A later. Unfortunately, I'll be in the middle of my case, so I'll try and answer this. So there are patients still coming to clinic. Oh, it's gone. Here we go. There are patients still coming to clinic who've had an op after an X number of years. Is there an understanding of life expectancy for those not eligible for an operation? So yes. So in truth, we can generally give you a reasonably good idea in terms of the extent of disease, and I think normally we tend to try and steer you away from life expectancy, mainly because I think whatever people say tends to be wrong. And that's not for sort of any reason, but because every patient's disease behaves differently. However, if we were to take the sort of information we have, and by that I mean extent of disease. So if you've got, if the patient has a primary cancer with secondary disease elsewhere, and then we know what the grade of disease is. By that I mean grade 1, which is the Ki-67 growth rate is low. Then even in those cases, we could say to patients that actually we could expect life expectancy to be longer term. If it's higher grade disease with quite advanced disease at multiple sites, then of course we have to be quite realistic and say, well, you may need chemotherapy type treatments, but life expectancy would not be as we would expect for neuroendocrine, sort of disease of the first grade. So we can generally give patients a reasonably good idea, but also you have to look at the pattern. So if you've got someone who's coming to your clinic who has secondary disease, but actually it's staying stable across scans over 2, 3, 4, 5 years, then actually we could be quite positive, I guess, about where they're going in the longer term, that they still have disease, they still have secondary disease, but actually it is not really behaving in an aggressive fashion, and actually they can expect to be much the same 4 or 5 years down the line. I hope that answers it.
Okay. I don't think we've got any other questions at the moment, but we do have a Q&A session at the end, so we can come back to any questions that people think of in the meantime. So if you can stop sharing your screen, Arjun.
I will do.
Thanks, Arjun.
Thank you.
And so thanks very much, Arjun. We will move on to Zia now. So I'm just going to bring him into the room. Hopefully he will appear. Okay, so Zia, you're a panelist now. Hopefully you can hear me. You just need to turn your video on and unmute yourself. There we go. Okay. And you just need to unmute yourself as well. Perfect.
Is it coming?
It is. You're on. So you should be able to share your screen now too.
Is it on, Joe?
Yes. We can see you and we can
Sorry,
hear you.
I can't hear you. Are we on the share mode?
Yeah.
Good. Can't hear you for some reason, but I'll start talking.
We can hear you. We can hear you, Zia. You just need to share your screen and then you're good to go.
Can you see it now?
We can see you, Zia, but you need to share your screen.
So we can see your screen now. Perfect.
Brilliant. Okay, thank you for inviting me for this talk. And I've been given a talk for this nuclear medicine session, which most of you might be or might not be aware of. But those of you who are going through PRRT are well aware of our department. So without any delays, because it's a complex subject, but I'll try to make it as simple for you as possible. So my specialty, unfortunately, it's surrounded by mystery, fear, and myths, as you all know. But in actual sense, what is nuclear medicine? So it is a medical specialty that uses nuclear, which is a radioactive particle element in the diagnosis and that of treatment. And this is the perception we usually get on the first go. But let me emphasize that this is not a military grade kind of radiation that we will be putting you through. It is just a medicinal grade. What is the essence of nuclear medicine? So when we go through all this CT scan or a specialized kind of scanning, it makes the invisible visible. And that, in a key element, I can describe it. What is the role and the function of nuclear medicine? It places a target on the disease so that a man on a galloping horse, as you can see over here, can see this target, which was very challenging and very difficult to see on other kind of imaging modalities. So let's come back to what neuroendocrine tumors are, and we call it NETs. Thank you for Judith and also Arjun for placing this stage for me. And most of us now have an idea what NETs are. But why are they challenging? They are basically challenging because they are a specialized kind of embryonic cells, as Judith described and explained in her talk. They are more indolent, so that is the bit of the question which was posed to Arjun. And they are not as aggressive, or they are not thought of as aggressive as the adenocarcinoma or other type of cancer cells. What makes them challenging, in addition, is also their capability of producing this carcinoid syndrome, which Judith explained in her talk earlier on. And these carcinoid syndromes may or may not be affecting you in types of flushing, diarrhea, tummy cramps, and wheezing. So in a nutshell, just to recap what has been already told, but in a different angle, what is the disease profile of neuroendocrine disease? So it can be anywhere. That is to tell you that such a heterogeneous group of disease that it can be found anywhere in the body. And this is a very important take-home message as well on this slide, that these NETs are not a pancreas. I think Judith also alluded earlier on in her talk, which is very good. And this is NET is not a lung cancer, although it might be presenting in the lungs. Similarly, in gastrointestinal tract or stomach, it might all be there, but it is a NET. So we have got a very, very vast and versatile type of diagnostic algorithm, and it goes on for years, as Arjun has told you. So just to recap that, it all starts with patients having symptoms. Something is not right, you visit the doctor as you should, and then the ball starts rolling. And then we come into the scenario of investigative medicines. I think my colleagues have covered this, what kind of bloods which are needed to be done, and what do we do. So it's all kind of hormonals and chromogranins and not. Then, as Arjun has already described, it kind of, we need to have a basis of the neuroendocrine tissue, which might be found and gathered on a surgical table or through a biopsy. Most importantly, we need to find the grade, which is given to us by our pathologist colleagues. And then ultimately, the images, such as myself and the other colleagues in the radiology, come into play. Arjun has also told you about a few scans, and you can see the CT scans with the hallmark in the initial staging, but then we come in with a specialized kind of imaging. And you can see there is this receptor imaging that we are going to cover through the nuclear medicine side, and these are the MRIs. So it is kind of a multi-modality approach that is taken to deal with the neuroendocrine tumors. A very important thing for the audience, that it is not a one-man show or a one-doctor show or one specialist show. It is a challenging disease. And because of that, there is a whole multidisciplinary team board which is involved. So you can see the surgicals, nuclear medicine, radiology, interventional, pathology. So there are many, many people in our board who is there to take a decision for the best kind of management for that individual. Again, something that we all consider in our MDT through multimodality approach, as I've shown you. So this is the basis where we get the tissue histology, and the KI67, I think Arjun has mentioned already, it shows what kind of a grade of the disease. We also embark on the anatomical imaging, then comes the nuclear medicine side of it. We call it a functional imaging because it shows the function of that specific tumor cell or tumor receptors. And I have tried to make it in two sides of it because we have got different imaging going through the spectrum. So you can see on the left-hand side, this is the receptor base, which I will come to it in a moment. And we have got an FDG scan, which is a different kind of a PET scan modality, but it will show us which form are we going through or which type of neuroendocrine disease we are going to. Prognosis is also discussed. Indolent, slow growing, they come in the well-differentiated column or they are aggressive. And you can see the FDG tells us the aggressiveness from an imaging point of view. Treatment options. There's no one treatment option, and that is the whole point of this MDT board for neuroendocrine disease. And we discussed the best possible outcome. I think it has been discussed in the prior presentations what difference. So there was chemotherapy, there is surgery, and I've tried to mention when it is appropriate or not. And Judith also mentioned about everolimus, which is also a novel chemotherapeutic agent. But we have got somatostatin analogues, I'll discuss it, and on the basis, then we have got the nuclear medicine therapy, which is the radionuclide. In terms of our ammunition from the functional side of imaging, it is also discussed with the selection of patients, which is key, who goes for functional imaging, because it helps in detection and localization of functionally active disease. That is very, very important in NET, whether it is functionally active or not. And our scans, they also help in monitoring the disease and the disease response to it, and also the progression, or after being so many years of gap, has it also relapsed or recurred? So what kind of different probes? There is a whole gallery of nuclear medicine probes in terms of imaging that we come through, but we will focus on the main ones, which the top one is the receptor affinity imaging. I think it is very, very clear to you that the targets which were shown on the earlier presentation, the somatostatin receptors, they are present on this nuclear medicine and nuclear cancer cells. And they can be imaged for their functionality with different kind of probes. Some are with the modality of SPECT-CT, while the others with the modality of PET imaging. Then we have got, because it all is started as a neuroendocrine, neural crest cells, some of the cancers, they are not that much functionally active in visual way from these kind of probes available in nuclear medicine. So we have other types of probes for scanning, namely MIBG and also the DOPA. And the other PET-CT, which is very common that we use, which shows us the metabolic activity or aggressiveness of this tumor, is seen by FDG PET-CT scan. So I've tried to give you a snapshot of different kind of tracers I've just spoken about. So this, you can see an MIBG scan, and it shows some, but not all. Similarly, if the same patient has gone through an FDG PET-CT scan, you can see different pattern of the disease on this one. Similarly, if I put through to a different tracer for the same neuroendocrine patient and have advised a gallium-68 PET-CT scan, you can see the functionally active cancer cells which are mapped out on this disease. Similarly, the SPECT-CT is also like tetrotoid scan or an octreotide scan. You can see disease patterns shown in this one. So we have the ability to look at and to seek the cancer cells from different nuclear probes. And this is a diagnostic algorithm that we are going through. Now, I need to mention, although we have got different types of nuclear tracers with us, but when it comes to the therapeutic arm of it, we have to make a judgment call. So on the left-hand side, you can see it's a F18 FDG PET-CT scan, and you can see the disease or naughty cells or the cancer cells, which you like to call it, is more evident and more intense, while the same patient is not showing that much functional activity on the gallium-68 PET scan. That means that there is less chance if this patient goes for a therapy, which is nuclear therapy or PRRT therapy for this patient. It might suit for him or her to go through chemotherapy. Now, an algorithm, so on the right-hand side of this picture, you can see it is nicely mapped out the disease of functionally active. And this is all measurable disease and appreciable disease. So this patient is suitable for PRRT, or what we call a receptor-based therapeutic. So for us, at this moment in time, the current inclusion criteria for progressing to PRRT is inoperable or metastatized neuroendocrine tumors. Cornerstone, once again, we need to have a tissue sample which shows it is neuroendocrine tumor, usually the well-differentiated ones. We have to see that the octreotide or tetrotoid or gallium-68 is positive in that patient. And the patient has a good blood and other renal functions. I'll talk about this in the next section of the PRRT. They should have both a structural imaging, which is the radiology component, CT scan or an MR scan, and they should also have the functional imaging, which is the nuclear scans I just showed you. Self-sufficient, independent, and how the patient is doing the daily activities is also very, very important for us. And the patient should have a life expectancy longer than 3 months, and over 99% of the patient group which comes to this neuroendocrine belongs to this. Final decision is always taken in the MDT with the board, that what is the management plan should be. So we, from the nuclear side, need to have a comprehensive kind of achievement in progressive disease, which is either made by the structural imaging, but most importantly, the functional imaging. High tumor burden or load where a waiting approach is not an option. Symptoms that cannot be managed by medication, inclusive some of the things like chemotherapy and other modality of treatments. This is what the outcome, if the patient is moving towards the nuclear medicine, that we receive a referral and it is handed over to us as our specialty to go forward and consider this patient for nuclear medicine or PRRT. So what is PRRT? So this is a peptide receptor radionuclide therapy. This is similar to the somatostatin receptors, which my previous colleagues have mentioned. And I will explain this a little bit complex diagram, but try to make it simple. But what is PRRT? In a nutshell, it seeks and targets the tumor cancer cells for radioactive approach to treat the thing. At this moment in time, we are using lutetium dotatate 177 as the main compound. So just to explain what is happening in as simple as I can. So if these are cancer cells, these neuroendocrine cancer cells have these somatostatin receptors, which make us to scan them on the diagnostic arm, and the same diagnostic arm then lead us to make a therapeutic arm with the help of lutetium. So this is the analog. If we do not put this radioactive head, it acts like the somatostatin analog medical therapy. While if we put it with a radioactive arm to make an internalize and then radiate the cancer cell, then this becomes radionuclide therapy with PRRT. I'll try to explain it in more simplistic fashion. If this is the tumor cell, it has got the biological target, which acts as the lock. Then we come along with our radiopharmaceutical, which attaches into this. However, we also link it with a radioactive head. And how the targeted destruction occurs is, this is a very important slide with a bystander effect and also the crossfire effect. So what happens if, just for the sake for explanation, if we target this cancer cell, the adjacent cells of the cancers will get its effect and targeted destruction. However, the surrounding cancer cells, they are also going to get the radiation and they are going to be targeted. And that is why the term target is used, because it's targeting the tumor cells. And hence, the amount of side effects associated with this type of therapy is much lower in comparison to other forms of systemic therapy, which may be toxic to normal cells. So a brief profile, I know it's very, very complex, so I'll try to stage it. So the highlights. So the lutetium PRRT, what is the treatment? So it is an intravenous, that means in one of your veins, we will inject 7.4 gigabecquerels of lutetium dotatate, that is the radiopharmaceutical. And it will consist of 4 divided cycles or fractions, whatever you would like to call it. And we will give at least 8 to 12 weeks in between each therapy. And there will be a total of 4, as I have mentioned. And this 4 deliveries with an interval of 8 to 12 weeks will make one complete treatment. Side effects, the complete list can be seen into the brochure, but the most important one, which we take into account, is the kidney function. Because this radioactive element, it is secreted or excreted out from the waterways. So kidneys are the main sites where they get most of the radiation, other or outside the targeted cancer cells, for which we always provide a protective amino acid fluid when the therapy is given. Similarly, reduced blood counts because it is radiation, and bone marrow, which are the factory houses of a lot of blood cells like hemoglobin or your infection kind of cells, WBCs, white cells, and all that. The other forms of effects which are worth mentioning is nausea, vomiting, lethargy, but most important, tumor-related pain, because this targeted treatment has not had an effect previously to the cancer cell. There might be an episode of flare where the symptoms go higher before it settles down. But all these, especially these two, are transient. What are the key considerations? Is the timing with the cold or non-radioactive somatostatin analog medications, which are the cold somatostatin analogs like sandostatin or lanreotide. If the patient is on, we have to target it around that. And we have to do the regular monitoring of blood and renal functions. There's the NETTER-1 trial, on the basis of which this treatment has been approved on the UK. Although I must say this treatment has been ongoing from the early 90s. So you can see the two-arm group where the treatment has been given and where there was no radionuclide kind of therapy. And to be very honest, look at this progression-free survival as comparison to this. This is just to show the graph. The green one is the progression-free survival in this trial with patients who did receive lutetium, while on this arm, this is a placebo, where lutetium was not given. And there is a clear-cut hazard ratio, which is ratio which tells you if there is any effect during the treatment, during the whole point of treatment. Briefly, I need to tell you, once the patient has been referred to us and we think that it is appropriate to give this therapy, we just formulate a clinic appointment. The first clinic appointment, it is more of an icebreaker, meet and greet, and just to have a review of all the investigations and history for the patient. We go through a detailed process of explanation of the procedure and potential side effects to it. And most importantly, radiation protection advice is discussed. And any questions with regards to this treatment is discussed in this clinic appointment. We make a slight judgment call whether it is appropriate for the patient to receive a day case treatment. That means a same day, or we need to involve this patient and keep him as an inpatient for 24 hours. And then we also discuss potential therapy dates. On the day of therapy, it is quite a hectic and a long day for the therapy. It's an early morning arrival, which is necessary. Then we do the clinic assessment and establishments. We give the therapy administration of 7.4 gigabecquerels, as I mentioned before. We do the radiation monitoring throughout the day. And then we do a post-therapeutic scan to check whatever therapy that we have given this patient is also being measured inside of a scan. And then we discharge the patient. It could be a same day or it could be a 24-hour. This is just in a nutshell a capture of what our UHS practice is. It is the initial kind of appointment followed by the therapeutic day, which shows a complete cycle and pathway for a patient. Actual delivery on the day, it has got a specialized equipment for delivery, and we do the consent on the same day. We need to have clear guidance of radiation protection because we are handling with a lot of radiation in one go. And similarly, at the time of infusion and disposal is very, very necessary. You can see this is the patient which showed all the receptors and positivity to begin with. And with serial time, you can see the change and the effect of this therapy. And after a year of this scan, this is serial time points, and this is nearly after 18 months of how the disease has shrunk with this PRRT. This is what we got patient feedback. We started and developed this service, or shall I say, redeveloped this service back in April 2019. Now I've delivered around 115 PRRT since April 2019, and these are just some of the comments. These are the comments and acknowledgement from our UHS Trust Board that we might be doing something right here. Just getting acknowledged. Thank you very much. I think I've tried to make it as simple as I could. It's a very vast subject. It's a lot of physics and clever medicine involved. Thank you for giving the opportunity. Thank you very much.
Thank you, Zia. You have got one question, which I'll read out to you. So, hi Sharon. At the moment, gallium-68 scans have to be performed in London. Will these ever be performed in Southampton, which I think Judith mentioned was hopeful earlier? And if so, how soon? Not sure if you know.
Well, yes, gallium-68 PET scan is one of, as I said, an important functional imaging. Our patients, we are very well aware they have to travel to London. At the moment, we are with the talks with the providers to establish it. We are one of the center of excellence over here in the region. But yes, that is one of the effects. It's work in progress, and we are definitely working for it to happen in Southampton.
Thank you very much. Okay, so thank you, Zia. So we are running a little bit behind, which I think we expected. So we're just going to take 5 minutes so everyone can go to the loo, make a cup of coffee, whatever you want to do, and then we will come back into Sachin's presentation next. Okay, so
thank you very much.
Hi everyone, so hopefully you are back from whatever you needed to do. I'm going to pass you over to Sasha now, who is going to speak about interventional radiology. And will hopefully be sharing his screen in just a second.
Okay, I hope you can all see that, and I hope you can all hear me.
Yes, perfect.
Great, okay. Hello everyone, my name is Sachin Modi. I'm one of the interventional radiologists, and I'm going to talk to you about the role of interventional radiology in neuroendocrine tumours. So these are my disclosures. So interventional radiology, who are we? I'd like to think of us as like the Ghostbusters. We're a bit geeky. We've got fancy equipment, and we like to get rid of bad things, especially in the liver. So if you come to radiology in Southampton, you may well encounter Dr. Tim Bryant, Dr. Steadman. We all know Dr. Steadman. Who could forget his dance moves at last year's Planets events? And me, the new kid on the block. Well, you could say new, but I've been here for 5 years now. You might recognize me from my fancy scrub hats. They're not religious, as one patient once thought. So interventional radiology, we have a huge role in a wide range of medical conditions, able to dissolve clots, freeze tumors, open up blood vessels. But one of the key areas which I'm going to talk to you about is poisoning tumors in the liver. And this brings me on to the area of interventional oncology, which is fast emerging as a new area in the management of cancer care. So traditionally, patients were managed by medical oncologists with medications or chemotherapy, surgery, which obviously you know, and radiation. But now we've got this new pillar of interventional oncology, which has an emerging role. So you probably heard some of this before, but the most common neuroendocrine tumours typically occur in the midgut, and these are functional, followed by the foregut. We divide these neuroendocrine tumours into low, intermediate, and high grade, and this is dependent on how quickly the cells are dividing, and the quicker the cells divide, the more aggressive the tumours. So neuroendocrine tumours from the bowel or the pancreas can typically be responsible for liver metastases, and liver metastases can be the dominant part of the disease. And this can be a problem for patients due to the tumour burden, so having the effect of having all those tumours in the liver, and obviously, as we've heard from Judith and Arjun, about the symptoms related to liver metastases, because these can also be secretory. And liver metastases are, in neuroendocrine tumours, the most common metastatic site. So the ENETS guidelines recommend that tumours that are G1 and G2, these patients are candidates for liver-directed therapies to try and control the liver tumours. And patients with G3 carcinomas are usually candidates for systemic therapy because they have metastases in the liver as well as other places in the body. So what are the goals for interventional radiology or interventional oncology? Ideally, what we want to do is get rid of all the tumours in the liver. This is not always possible, but what we do want to try and do is get some control over the disease in the liver. And this, we know, results in patients living longer. If you think of the liver as sort of the main engine room of the body, like a sort of garden, and these tumours in the liver are sort of like weeds, what we want to try and achieve is to control the weeds in the garden so that the liver can function normally. We can sometimes do better than that. Sometimes we can make the tumours go away completely. Sometimes we can help out Arjun and Tom. If we can get very good responses to our treatment, sometimes patients can go on to have surgery. And we can also control some of the hormonal symptoms which some patients get when the somatostatin analogues fail. So the intra-arterial therapies are sort of banded into these three subheadings. So transarterial chemoembolization, which is the delivery of small beads with chemotherapy on them into the liver arteries. Transarterial embolization, or TAE, which is embolization or delivery of small beads into the liver arteries without chemotherapy. And selective internal radiation therapy, or SIRT, which is the delivery again of small beads, but this time with radiation. The first two are very similar, the only difference being with the chemoembolization, we add in the chemotherapy, and I'll talk to you about these now in more detail. So why do these therapies work? Well, The liver, this is due to the liver having a unique double blood supply. So 20% of the liver is supplied by the hepatic arteries and 80% is from the portal vein. So the portal vein carries all the nice blood from the gut into the liver. And the difference in this blood supply is important because tumours in the liver, either metastatic or primary tumours, tend to take their blood supply from the arteries. And this enables us to deliver artery-based treatments to affect the tumours without affecting the normal liver. Okay, and neuroendocrine tumours are especially good candidates for this type of treatment because they are very rich in their blood supply. We like to call them arterialized, and therefore they're a very good target for this type of therapy. So this is just a picture showing 80% of the blood supply from the portal vein, 20% from the hepatic arteries. This is a CT scan here, and this structure here on the left-hand side of your screens is the liver. On both sides, there's two different patients. We can see this is a scan with contrast. There's the blood vessel, main blood vessel here is bright, the aorta, and we can see the patient on the left is a neuroendocrine tumor patient. Nice tumor here, well, not nice, but very bright tumor taking up the contrast. And this is a patient with metastasis from colorectal cancer. You can see these tumors are not taking up the contrast as much. And this is why neuroendocrine tumors are very good candidates for artery-based therapies, because they're so sort of blood hungry. This is an example of us in the liver artery. So this is a catheter that's which is a tube which has been placed in the liver artery. And you can see when we inject dye, we can slowly see that as the dye goes into blood vessels, we can slowly see these tumors, these rounded areas appearing within the liver. And this is what makes them good candidates for these treatments. And this is another example here. So the first injection, as we go on, you can see this network of blood vessels here within this tumor getting brighter and brighter. So how do we select patients? We want to choose patients that are generally quite fit and well. We want patients whose normal liver function is okay. We don't want to treat patients whose livers are not very happy, because we can make things worse. PVT is something called portal vein thrombosis, so that's blockage of the portal vein. We don't want to treat patients with portal vein thrombosis because, as I said to you, we're just treating the liver arteries, we're blocking them off. If we were to block the portal vein, which was already blocked in patients, it would result in liver failure. So we don't want to treat patients with that. We generally like to treat patients with disease less than 50% of the liver. Some patients have had surgery, so biliary enteric anastomosis is where Arjun and Tom join the bile ducts to the bowel. Sometimes those patients can be more prone to infection, so we have to be slightly careful with those. So this is a patient who's got a large volume of tumours in their liver, so over 50%. So these are the type of patients we'd be very cautious with. And when we're treating these patients, we often do this in a staged manner. So we'll treat one side or one part of the liver first, and then another part of the liver in a separate sitting. So we don't want to have a huge effect in one go. So as you've heard at Southampton, there's no sort of one-size-fits-all treatment. Everything is bespoke. All patients are discussed at our MDT with a wide range of clinicians. And when patients are deemed suitable for interventional radiology, we see them ourselves in our interventional radiology clinic with our clinical nurse specialists, Vicky and Sam. Patients often come in the day before to have octreotide, which, as you've heard about, suppresses the hormones which these tumours secrete. And we find this useful to give before our treatments, because when we give our treatments, we can make the tumours quite unhappy and they can secrete more hormones. So this is the sort of protocol where patients come in either the day before to have some octreotide to reduce that effect. Generally, patients stay overnight for 1 to 3 days. Patients will get something called post-embolization syndrome, which is sort of a mild discomfort for 7 to 10 days, maybe some pain around the liver, some nausea, some feeling a bit sick, a bit tired. And usually those are self-limiting. We send patients home with some painkillers and some anti-sickness, and our clinical nurse specialists call every couple of days afterwards to check that you're okay. The patients generally have a CT or an MRI scan at 6 to 8 weeks afterwards to check the result of the treatment, and then we rediscuss the MDT, and if there's any need for further treatment, then we go ahead with that. So as I was saying, the principles of treatment, so these patients generally have a normal background liver, so we want to be careful. We don't want to be too aggressive with our blockade of the blood vessels. We don't want to damage the normal liver. In patients with lots of tumours, we tend to treat sort of the right lobe first, then the left lobe, or even segments of the liver at a time. And generally, these treatments are 4 to 6 weeks apart. What we want to do, if you imagine the blood vessels of the liver like the branches of a tree, we want to put our catheter into the main blood vessel, deliver the particles so they travel further out into the branches and gradually block off those blood vessels until the main blood vessel is blocked. We don't want to completely block the blood vessels. What we want to do is slow the flow to the tumour and deprive it of its blood supply. We use various different tubes and wires to get into the liver blood supply like these, and then we use even smaller tubes to get in further. If we can be as targeted as possible, that's best. So this is an example of a patient who had these 2 neuroendocrine tumours. So this is the liver here on the screen. This is one large tumour here at the top of the liver and another smaller one here at the bottom. Patient came to have their TAE procedure. So this is an injection in the liver blood vessels, and you can see these wiggly blood vessels, and you can see faintly the tumours are enhancing here at the top. What we did was we maneuvered our smaller catheter all the wiggly way through these blood vessels. Once we made sure we're in the right spot, we then inject these small particles which block the blood vessels. And this is a scan after 6 weeks. You can see now there's no more brightness with this tumor at the top. It's also reduced in size, and the same here with this bottom one here. So it's not completely gone, but it's not enhancing anymore, which means it's not living anymore, and it's much smaller. So this is the control of the disease that I was talking about. This is another example. So this patient had lots of disease in the left side of the liver. So this time we just went, this is the left liver artery here where my arrow is. So we put our catheter into the left liver artery and we delivered these beads. And you can see here, lots of these tumors here, which are now not taking up any blood supply. They're all sort of dark in color, meaning that they are essentially dead or under control. Okay, so you can see that. So we often, sometimes when we want to do trouble solving, or we want to make sure we're in the right blood place, when we're doing this, we do something called a rotational CT. So you may be in our interventional radiology lab and the machine will spin around you. This enables us to get more pictures, better detail. So it gives us a sort of, not as good quality, but a nice CT scan where we can see which tumors are lighting up and where we need to deliver our beads. Some more examples here. So you can see injection into the hepatic arteries, tumor blush here, and then after treatment, no more tumor blush. And we can convert people to surgery. That was that patient who, after this tumor the blood supply was blocked, they went on to have surgery to have it removed. So this is what I was talking about. The tumors have a very rich network of blood vessels, and we have to target these blood vessels accordingly with the size of our particles. When we're talking about TACE and TAE, we're using this sort of particle size, 100 to 300 microns, to block the feeding blood vessels to the tumor. What's the evidence for using TACE? So this is a study from Indiana which shows that using TACE in NET hepatic metastases does increase survival. And the graphs here show increased survival with the use of TACE. We have to be wary, we have to be careful. There can be complications. So this is a patient where, because of the normal liver, they did suffer some damage to some of their bile ducts. So you can see the bile ducts here are dilated in this patient's liver, and that's something that can happen. We have to be careful about. This is another patient who had a tumor here at the bottom of the liver. They had a TAE procedure. You can see the tumor is nice and dead, but you can see it's got some air in it. It was a little bit infected, and this can happen to tumors once they start to die. The patient had some antibiotics, and this is their final scan. So you can see the tumor is much smaller and looking good. So on to something else, radioembolization. So radioembolization is different treatment to TAE or TACE. Unfortunately, it's not available on the NHS, although there is a lot of work going on behind the scenes to try and make it more accessible for patients with neuroendocrine metastases, because it's again an ideal tumor type which would benefit from this treatment. So it's slightly different to TAE or TACE. This time we're delivering beads which are much, much smaller. And these beads have radiation on them called yttrium Y90, which emits radiation between 2 to 1 to 2 millimeters. What we want to do is get these smaller beads in the tumours so that they can have a radiation effect sort of from the inside out, as opposed to normal radiation, which is from the outside in. This procedure involves patients coming in at 2 stages of the hospital, although recently we performed our first day case procedure. So usually patients come in, they have a workup procedure. This is different to the TAE because we want to make sure that the liver blood vessels are not supplying any other blood vessels. We don't want to deliver these radiation beads to the stomach or the bowel. So here's an example of this patient where we wanted to deliver beads into their liver, but they had this blood vessel here at the bottom that we had to coil off to protect. So this is what we do on the workup procedure. What we then do is, this is another example, so this is a blood vessel supplying the anterior abdominal wall that we have to look out for, and this is an example of some coils in there to protect that blood vessel before we deliver the actual radiation. So patients come in for the workup procedure, which is a day case. That we take some pictures of the liver blood vessels, block any blood vessels that we need to with these coils, and we deliver a test dose of the radiation so we can see exactly how much is going to the tumours, making sure that nothing's going in elsewhere. This is what happens if we're not careful. So this is a patient who had some radiation through the blood vessel to the anterior abdominal wall, so a little bit of skin necrosis here. And then what we do is we calculate the dose that we're going to give to the tumours. And we need to be very careful. We want to make sure that we're targeting the tumours, not the normal liver. And what we like to deliver is 120 gray, ideally, to the tumours. And this is the software we use to calculate all this. When the patients come in, usually 2 weeks later for the actual delivery of the radiation, that procedure is done with an overnight stay. They usually stay in a side room for 24 hours due to the radiation. And we do a scan the next day to make sure that the radiation's gone where we want. And this is what we want to see. We want to see on these nuclear medicine scans that the tumours are lighting up with the radiation that we've delivered, and this indicates that these patients are likely to have a good response. So what can happen after radioembolization? So patients can get a similar type of pattern of symptoms similar to the TACE, where they get a post-embolization syndrome with some nausea, pain and fatigue. There can be infections or abscesses formed after these treatments, but generally it's a very well tolerated procedure. We have to be careful of the radiation dose to the normal liver. We don't want to cause radiation damage, but that's why we do all these clever calculations to make sure we're giving the right dose. Usually follow-up is in 2 to 3 months. We don't like to scan too early because sometimes the initial scans can be misleading. So usually we scan at 2 to 3 months. And this is again evidence for treatment with radioembolization in neuroendocrine tumours. So a vast majority of patients in this 42 patient study had a stable disease or a partial response to treatment. So it's really something that we want to do more of here in Southampton, and hopefully something is coming soon to enable us to do that. So what else can we do in interventional radiology? I mentioned artery-based therapies, but there are other treatments that we can offer here. So if patients have 1 or 2 tumours, these can be ablated, which is essentially putting a probe into the liver and burning the tissue of the tumour and around the liver. This is another patient that I treated who had a tumour in his pancreas, an insulinoma secreting insulin. So here you see this bright spot on this scan is the insulinoma. And we actually went into the small artery supplying this and blocked this tumour off here with small beads. And the patient did very well, didn't need any more infusions of insulin, so it did very well. We've done 2 patients like this. So there's lots of new and evolving things. One of the areas that we do quite a lot of here in Southampton is chemosaturation therapy, which I'm sure you've heard of before from Dr. Steadman, but currently we're using this for patients with a rare type of eye cancer called ocular melanoma. This treatment enables us to similarly give chemotherapy into the arteries, but in this case, we're able to give a very high dose of chemotherapy because at the same time, we are capturing the blood that's coming out of the liver and able to clean that blood through a filter circuit that you can see here outside of the body and back into the neck. And what this enables us to do is to give a very high dose of chemotherapy to the liver to get these tumours under control or kill these tumours. The drug we use is melphalan, but at the same time restricting the amount that is the whole body is exposed to. And we've done, you know, up to 250 treatments now in patients with ocular melanoma. We've got very good results, and we hope that in the future we will be able to use this for neuroendocrine patients as well. So that's enough technical stuff. I wanted to talk to you a bit about us and what's happened during COVID. So as you know, during the peak of the virus here in Southampton, things were very quiet in the hospital. This is some of the pictures from the main hospital lobby. Neil's office is around the corner here. It was very quiet. The hospital was essentially shut to visitors. We changed our working pattern. We only had 3 of us on site at any one time because we wanted to protect ourselves and protect our patients. We were still allowed to perform cancer treatments, so we were still doing TACEs and TAEs and CERT treatments during this time. We've got a new day unit in interventional radiology, and what this day unit enables us to do is bring in patients directly. This is just a video going through the hospital, but you'll come to our day unit. What it enables us to do is bring in patients into our day unit directly, have their procedures performed in interventional radiology, so that there's sort of, you know, that is coming into a clean area of the hospital. And this is just a video. So this is our day unit here. This is first thing in the morning before we have our team brief. So it's got a male bay here on the left with 4 beds, and then it's got a female area here on outside. And this is our new lab, which has just been built this year. So this is our new interventional radiology lab with our new spanking brand new machine, where we do a lot of our procedures. So this is, we kept going throughout. This is some pictures from us having some PPE training. We were very kindly donated masks from a local school for visors. We've recently got some really lovely scrub hats, so thank you all, thank you Planets for that. We've all got our own scrub hats. And, you know, we're a big team here in interventional radiology with the doctors, nurses, radiographers and specialists. And we're all here ready and, you know, ready to treat you and offer you the best care. So thank you very much for giving me the opportunity to speak at this lecture. I'm more than happy to answer any questions either today or at a later stage. My colleague Tim Bryant is running 1 million meters in November with his son and one of our other colleagues. So he'd be grateful for any donations if you guys can. So thank you very much.
So Sachin, I don't know if you can see the questions that there's a question on the Q&A box.
Yes, I can see. Does chemosaturation only work for ocular melanomas, or could this work for other types of liver mets? I think that's an excellent question. So in Southampton, when we first started out doing chemosaturation, we've been doing it purely for ocular melanoma mets. So we wanted to prove the safety of the procedure because it's quite involved with this bypass and things like that. And we wanted to prove the efficacy. And we've now done a sufficient number of patients whereby we know that it works well, it's safe. Patients go home after 2 to 3 days. And I believe it does work for other tumours. Other centres in Germany have tried it for other cancer types, including neuroendocrine, and the results have been positive. So it's something that we hope to do here in Southampton, given that we have a huge experience between Dr. Steadman and myself in doing this. And you know, we hope to watch this space. You know, we'll hopefully do some patients soon.
There is some evidence for it. Not just anecdote, but in, I think about 2008, 2009, one of the initial studies was looking at neuroendocrine tumours. But they had a slightly different equipment and technique then, and some of their results were not so great.
Yeah.
But they did see tumour response, but they did have more complications. Since they've refined the equipment, we don't have those complications anymore. But it definitely needs looking at properly again.
Yeah. We've got a question here from someone else. Interventional radio looks great. How do we get this on the NHS? So a lot of these treatments I talked about are available. So the TAE and the TACE are mainstays. We use that very commonly here in Southampton. Some of the other treatments like CERT, which we'd like to be able to offer to more patients, it's not available in the NHS yet, but it's constantly under review, and there are people working behind the scenes to try and get it approved. We're hopeful that we may have some funding in terms of a trial soon, whereby me and Dr. Stidham will be able to provide some more CERT treatments for neuroendocrine patients. So we're working on it, and let's hope it brings something fruitful soon.
Okay, so I don't know if anyone's got any other questions, but if some do pop up, we can do that in the Q&A at the end. Thanks very much, Sasha, that was really interesting. And we are moving on to...
Hiya, let me just share.
Ruth's going to be talking about some general dietary tips.
Great. Can you see my screen? Is that working?
See your screen, yes.
Yeah, lovely. Okay. Okay, and you can see me as well?
Can't see you at the moment, and at the moment your screen is just a screenshot of me, unfortunately.
Okay, there we go. Hopefully that works.
Yes.
Let's try again. Oh. When I share my screen, it turns my video off.
Just worry about your screen to start with.
Okay. Yeah. There we go. Hopefully you've got both now.
That's perfect.
Lovely. Okay. Hi everyone. My name's Ruth Lee and I'm Robert White neuroendocrine oncology dietitian. And today I'm going to be talking about NETs, nutrition and COVID-19. Please ask any questions. I'll try and answer them at the end. And I'm also going to be staying on later, so I should be able to answer any of them. So it's going to be a bit of a mixture of things today. There's a few things I wanted to talk to you about. So I thought it would probably be easiest if I just kind of did a little bit on each. First of all, who am I? So I am the Wessex neuroendocrine oncology dietitian. I started back in May 2019 and I work across Wessex and I've now seen about 200 patients to help with their dietary needs. So normally I'm doing clinics across the region, across Dorset and Hampshire, but obviously recently it's been a bit more kind of phone and video appointments. Then in terms of the areas I'm going to cover today, I'm just going to do a little bit about the causes of common causes of diarrhea in NET patients. I'm going to do a little bit about kind of COVID-19 and kind of how this links to NET patients and nutrition. And then recently I've done a patient feedback questionnaire. So I'll just be running through a few of the results from this. Okay, so chronic diarrhea. This is the most common reason that I see patients. And it's defined as the persistent alteration from the norm with stool consistency between types 5 and 7 on the Bristol stool chart and increased frequency greater than 4 weeks duration. So of course it's me, so I had to get a few pictures of poo in there. So as you can see, type 5, type 6, type 7. Those are all different types of diarrhea, and that's why I'm always asking my patients what their stools are like and to describe them a bit more to me. So I'd say most of my patients have for far longer than 4 weeks duration. It could be up to 4 years duration, in fact. And if this is something you're struggling with, then please get in touch with me. Okay, so what is causing my diarrhea? I'm not going to go into loads of detail here, but we are going to kind of go through the main causes of diarrhea in NET patients. And you can kind of get an idea maybe if any of these are applicable to you. And it might be that there's one that's applicable or a few that are applicable, or actually your diarrhea might be caused by something else. I'm just going through a few of them here. Okay, so first one, carcinoid diarrhea. So just be aware that you must have carcinoid syndrome to have this type of diarrhea. So probably your doctors or nurse will have mentioned it, or you might have been told that you have high serum 5-HIAA or urine 5-HIAA or high serotonin levels. The most common symptoms of this diarrhea is frequent stools. They're usually type 5 or 6, so not really watery, but just quite loose. Normally brown in colour, often get some abdominal pain associated with it. And some people find that it's worse with larger or fattier meals, perhaps with alcohol or spicy foods, or some people find there are specific food triggers for it. So you might have heard of foods high in amines that can trigger diarrhea. Okay, second one, malabsorption diarrhea. So this would be patients that are having octreotide or lanreotide injections, or have had pancreas surgery, or sometimes if you have a pancreatic neuroendocrine tumour. And the symptoms from this are regular stools, again, quite loose but not completely watery. The main thing here, though, is having yellow or cream stools, and they can sometimes look oily in the toilet bowl. They'll probably float, might be frothy, and they might be smelly. There could be some abdominal pain and burping after eating, and they could be worse with fattier foods. So then moving on to bile acid malabsorption diarrhea. So this is much more likely if you've had surgery to remove the end of your small bowel, they might call it the terminal ileum, and or your gallbladder removed as well. So with this, normally you get very, very frequent stools, and it's often quite soon after eating. It can be kind of any consistency from loose to very, very watery, can be any colour. Often people say about having their bowels open overnight. They might have some burning around the anus when your bowels open, or a sudden urgency, so needing to rush to the toilet and open your bowels. Could be bloating or abdominal pain. And again, it's significantly worse with fattier foods for most people. So going on to the next, small intestine bacterial overgrowth. This one's more likely if you've had a right hemicolectomy, so that's the end of your small bowel and start of your large bowel removed, or a Whipple's surgery. So again, you might have more frequent stools here, usually just slightly loose, but often it's accompanied by quite a lot of wind and bloating, and a lot of people say they can hear their tummies gurgling away. And the final one, short bowel diarrhea. So you will have had a significant amount of short bowel removed, and this will give you very frequent stool, can be quite loose, and the main ones here are weight loss and tiredness, because you're not absorbing all the nutrients that you're eating, and it's usually brown in colour. So as I said, that's just a very quick run through, and if there's anything that you are identifying there, please get in touch with myself or get yourself referred to me, and hopefully we can make things a lot better. So moving on to some COVID-19 dietary issues that might affect NET patients. And one of these is access to food. So I know some of my patients that I've been speaking to have perhaps been isolating, or really not felt comfortable going out to the supermarket, as they can be quite busy sometimes. So just a few tips here. When you do get your food in, or your food order, buy long life foods. So you can buy UHT milk, which can be just kept in the cupboard. Dry goods, tinned goods, stock up on all of these, so you don't have to go to the shop so often. You can buy frozen or freeze food on the day of purchase, such as fruit and veg, meat, fish, bread. In fact, fruit and veg that's frozen has just as much, if not more, nutrients in than fresh. Little tip there. Always ask friends and family for help, of course, and just think about using the national or local services. So I know some people are getting regular food deliveries, but if you're not included in that, there are also quite a lot of local services that are out there and able to help people that are struggling. So next, just going to talk a little bit about weight gain. So with lockdown and isolation, it's more difficult to kind of get out and exercise, and it's very easy just while you're inside just to, you know, eat a little more, snack a little bit more, and this can lead to weight gain. So obviously this isn't a concern for everyone, but if your BMI is going over 30, then that puts you in the obese category, and that's when we're starting to get a little bit worried. In terms of working out your BMI, that's body mass index, you need your height and you need your weight. And you can go onto NHS website, which will calculate it for you, or you can ask any healthcare professional, they should be able to calculate for you as well. And if you are kind of creeping over this BMI of 30, it's really beneficial to try and eat a bit more healthily and reduce your weight. As it has been shown that more of the patients being admitted to hospital are in this category, and there's more complications and it's harder to treat those patients as well. So a few tips to help keep your weight stable, or to help you lose a bit of weight if you'd like to. Have 5 portions of fruit and vegetables a day. Space these out throughout the day and have a good range of them. Check your portion size at meals hasn't increased, so it's very easy just to be having a little bit extra. So make sure you're kind of sizing them down a bit. Cutting down on unhealthy snacks, so easy to grab things kind of from the kitchen, and maybe switch to some more healthier snacks and more healthier desserts like fruit, yogurt, or crackers, and perhaps hummus or cream cheese. And also reducing the amount of fat spreads, so margarine or butter, and oils that you use as well. That will really reduce down the amount of calories you're having. So it's also important to exercise. This should be tailored to you, and you can do it, you know, even if you are just staying at home. You can do exercises within the house. Going up and down the stairs is great. Using a few arm weights, even doing the houseworks, all exercise. If you're lucky enough to have a garden, walking, or I know a lot of people have really got into their gardening, or perhaps walks or bike rides outside, avoiding other people. And the other kind of dietary issue surrounding COVID-19 that a lot of people have been talking about is nutritional supplements. And a lot of people are saying, you know, you can do certain things to boost your immune system. Unfortunately, there's no foods or supplements that can actually boost your immune system. That's not quite the way it works, unfortunately. A lot of people have talked about vitamin C and zinc supplements, but again, no evidence that these are going to stop you getting COVID or cure COVID. With vitamin D, again, that's another one that's been in the media quite a lot recently, in terms of if it's going to protect you from COVID, and people are saying that it's low in those that have COVID. But again, there's no good evidence there, and actually a lot of us are low in vitamin D at the moment, due to it being winter. So actually we do recommend that everyone in the population during the winter months takes 10 micrograms of vitamin D, just because we're not able to get enough from the sunshine here in the UK for the winter, and that's the main way that we get most of our vitamin D. Okay. So moving on to talk a bit about the patient satisfaction survey. I kind of designed a questionnaire, which was a few pages long, and we just wanted to get an idea of how patients felt their net dietitian service was going. We sent it out end of August, and it was sent to all patients that had had contact with myself from June 2019 to August 2020. Patients were given a month to complete it and return it in a prepaid envelope. And we sent 145 out and got 90 back. So that's a 62% response rate, and I'm told that's a pretty good response rate for a questionnaire like this. And it means that it gives quite a good representation of the NET patients that I have seen. So there were loads of questions in it, but I just thought I'd pick out just a few today, just to go through with you so you could see what people said. So this question was, the care I received from the NET dietitian improved my overall health. So as you can see from this graph, most people completely agree, and that was actually 71% of patients felt that their health had improved. 25% said kind of in between, and 4% disagreed. I'm not sure exactly why there were the people that disagreed, or maybe were in between, because they quite often didn't write a comment as to why that was. But perhaps it's something we could look into in kind of future questionnaires. So then another graph, this was a bit more complicated, and the question was, in what way did the dietitian's care improve your health? So as you can see along the bottom there, I had put a few ways that I thought I was improving patients' health, and then they could tick whether seeing the dietitian had helped a lot, which is the blue, or it had helped a little, which is the red, or if it wasn't applicable to some people, for example, they might not need to gain weight, so they would put it wasn't applicable to them. But of all those people whose health was improved, the best results there were improvement of 84% improved their stool consistency, 74% improved their stool colour, 72% improved their bloating and wind, and 70% improved their stool frequency. So huge improvements in bowels there, thanks to the things we put in place. But I was also really pleased to see that 82% of people said working with the dietitian improved their quality of life, because that's what's really important to me. You know, we can improve your symptoms and things, but it's making sure that you can really kind of go out there and live your best life. We also did some questions where people could just write, and this was was there anything the NET dietitian did particularly well? And it was great, because I had about 70% of people actually left a comment in this section, and these are just a few that I picked out that are really, really nice comments to receive. I'll just give you a few seconds just to have a quick read through of some of them. Okay, so moving on to the next slide. We also asked if there was anything the NET dietitian service could do better, and based on this, developed a few recommendations to the NET dietitian service that we could do. So first was offer more video appointments. A couple of people said that they're quite keen to have video appointments. I know this is quite variable. Some people would just prefer to speak on the phone, or obviously face-to-face, if that's possible, but we should be kind of offering more video appointments if we can. It would be good for the dietitian to attend all NET clinics. So by these I mean the doctors' clinics and the nurses' clinics, as then we can pick out patients that need dietetic advice. Always tailor advice to the patient. There are a couple of people that said the advice given wasn't maybe specific to them, and obviously that's really important. And again, we asked kind of what kind of information you got from the dietitian. And some people said they'd like a bit more advice on symptom control. So that's something we're just being made aware of. And finally, kind of the awareness of impact on mental and physical health. So making sure everyone's aware that the dietitian can do both of them. So in terms of how to contact me, there's my mobile number and my email. Feel free to get in contact with me directly, that's absolutely fine. Or if you feel more comfortable getting your NET nurse or doctor to refer to me, that's how I get most of my referrals, so that's great. I would say though that I'm actually going on maternity leave in 3 weeks, so if you do want to contact me, make sure you do it before then. Or there will be another dietitian covering me starting in January. She's called Alex, and she will have the same phone number there, so if you do want to write that down. That will be her number. And when we have her email address, I'm sure we'll be able to send it round. So that's everything from me. If anyone has any questions, I can have a little look.
Thanks, Ruth. That was really interesting, and it's great to see that you've made such a difference to so many patients while you've been in this role. So as Ruth said, get in touch if you did want to speak to her direct. We haven't had any questions, but I expect they're all quite personal and specific to you. So if you do want to get in touch direct with Ruth, then please do. So next up, if you can just stop sharing your screen, Ruth. We have got Andy Bates, who is from Westfit, and he is going to talk to us a little bit about the new online intervention that they are doing. So I'm just going to promote Andy to being a panelist. So he's our last speaker for today, and then we're going to have a Q&A session at the end. So think of all your questions, note them down, and we're keeping an eye on those as we go through. So Andy, you should be able to share your screen. Hi, thanks for joining us.
Thank you. Thanks for inviting me. I'll just go through the usual Zoom start to any presentation or meeting. Can you see my slide? Can you hear me?
I can hear you.
Okay, so can you see my slide?
No, it doesn't say that you're sharing your screen at the moment, actually. So
okay, let's try again.
Better.
Your screen is showing now.
Great. So you can see my slides.
Okay.
Yeah.
Perfect.
Fab. Thank you. Yeah. So classic Zoom call start. Apologise for that. So my name's Andy. Andy Bates. I'm actually by background an intensive care nurse, but for the last 4 to 5 years, I've been working as a researcher. Really within the critical care and anaesthetics research group. So why I'm ending up talking to you today, we've taken a journey through the primary focus of our work previously when I started was to best prepare our patients for surgery, for cancer surgery. You know, we had a group of patients who were facing a metabolic stress, which we knew was coming, and we often had a window of opportunity in which we could prepare them best for that, because we knew that fitter patients tended to do better, tended to sail through surgery more readily. So really how this has progressed now is that we're looking at the broader cancer care pathway. So all sorts of different kinds of cancer treatments appear to be amenable to being fitter, in better shape nutritionally, and also psychologically better prepared. And so that's what I'm going to talk to you about today. Okay, so a lot of you will recognise the Macmillan green on here. Why should we exercise? Why should we eat well and look after our mental health? I mean, it seems a sort of fairly simple question with a very common sense answer. And indeed it is true. There are lots of benefits. As you can see here, behind each one of these statements is a research program. So, you know, we know that patients who are fitter tend to leave hospital earlier after major surgery and after treatments. Obviously, being fitter is cardiorespiratory fitness. We all know the benefits of that. Reducing complications secondary to the treatments that you may all be experiencing. We've heard a lot from, so we've heard from surgeons, from chemotherapy with Judith, and from interventional radiology. Exercise, eating well, preparing yourself. improve your outcome from all of these things, we believe, but the evidence isn't really definitive. So that's what we're trying to do. Okay, so if it's common sense, and if it's that straightforward, why isn't everybody doing it? And why aren't we as clinicians helping everybody to do it? The evidence has been synthesized with all of these are international guidelines. So on the left-hand side of your screen is the Clinical Oncology Society of Australia. We've got the American College of Sports Medicine on the right. And of course, in the middle, our headline one in the UK, which our team was leading on actually, was this Macmillan guidance, Royal College of Anaesthetists and the NIHR, which is the research arm of the NHS, have developed the prehabilitation for people with cancer. And prehabilitation really encompasses diet, exercise, and psychological well-being throughout the cancer care pathway. This is freely available on the Macmillan website. It's really written in plain English. It's not designed specifically for clinicians and academic users. Everybody will hopefully gain something from it. And there's Della on the front cover, the cover star, who is a key member of our research team now. So she's gone through a couple of our trials, and she's working with us to make sure that the patient's voice is heard loud and clear. Okay, so the evidence is all out there, the guidance is all out there. So what we need to do is have a honest discussion about how much exercise we do. I presented at Planet's conference a couple of years ago, and it's always kind of fun to challenge everyone to stand up if you're meeting the Chief Medical Officer's guidelines. So it's 150 minutes. So it's 2.5 hours of moderate to vigorous aerobic physical activity. So that's something that's going to get you out of breath effectively. It's a slightly subjective term, but anything that gets you out of breath, gets your heart racing a little bit, plus at least 2 resistance training sessions per week. Now this is really important. We know patients, we all naturally lose muscle as we get older, but we can moderate that muscle loss, and it has very important implications for the cancer treatments that you may be facing. We've just recently completed a review of some evidence looking at the body composition of patients, and it seems that those patients who have more muscle, who have a higher proportion of muscle, tend to do better after surgery, which is obviously our primary focus. And there's also some exploratory evidence regarding a sort of an interplay between muscular activity and hormones, which is obviously crucially important for NETs patients. So for those of you who are standing up and saying, yeah, I do 2.5 hours of moderate physical activity a week, we all have to be quite honest with ourselves, don't we? I mean, it's, you know, what we perceive that we do and what we actually do is sometimes different. I recently received one of these, first time I've had one of these. It's a sort of activity tracker. And I research and I talk about exercise all the time, and actually quite horrified to find out on some days how little activity I actually do. I like this photo. It's obviously America, so it's an extreme example, but it kind of highlights the disparity often between what we think we do and what we actually do. The same, I mean, Ruth's just given some, you know, a really good talk about nutrition and the importance of really diet, and actually just the same principles apply here in terms of healthy eating guidance. I recently saw a report saying 13%, so that's 13% of men met the government target of 5 fruit and vegetables a day. And that's probably the most famous, best advertised, best understood piece of advice in diet and nutrition, I would think, from a relatively lay perspective. But only 13% of people, of males, are reaching that. Ladies are doing much better. It's about 21% for females, so well done. And of course, looking after our minds as well, our well-being, our psychological well-being. Receiving a cancer diagnosis, you know, is never going to be easy. It's never straightforward. It's always challenging. one of our research groups looked at psychological well-being, and that was also related to recovery from surgery as well. So those patients who are going in with a positive frame of mind, feeling well supported and well cared for, tended to do better after surgery. So there's a real it has real implications. So we've got all of this guidance, and yet we know, and most of it's well known, but we know it's very difficult to apply in reality. If that was the end of the story, certainly I wouldn't need to do the research that I'm doing, and everything would be fine, right? But we talk to our patients all the time. So Della, who is the cover staff, Millen is in the bottom right hand corner. She reports she's struggling with chemotherapy physically, but she's also disorientated. They talk about a bewildering array of, you have a diagnosis, then you have multiple discussions with multiple healthcare professionals, often looking at treatment modalities. Our patients tell us about the sheer weight of admin that they have to undertake, with all the medical appointments. For example, if you have radiotherapy, that can often be daily. You might have weekly chemotherapy, etc., etc., etc. So it's a blizzard of information all at the same time, and at that time you're also being asked to address your exercise and your nutrition and your psychological well-being. It's incredibly difficult. And of course, we can't go through a talk in the current climate without talking about the impact of COVID. There was a report, it's just been published on the Macmillan website again, talking about the forgotten C. I mean, obviously, healthcare professional, absolute believer in the science is telling us to socially distance, etc. But there is an impact. There is an impact that we need to be honest and address. For our patients, gymnasium closing, getting to the supermarkets can be scary. I was in the supermarket earlier this week, and there were a number of people in there without masks on. I find that very difficult personally. If you've got cancer, I would imagine it's even more scary. So it's having a very real impact for those people who are already diagnosed with cancer. For us, we were undertaking the largest prehabilitation trial. So we had an exercise and psychological wellbeing trial called WESFIT, which I talked about 2 years ago because we were just starting it then, and we were well underway. We'd recruited 350 patients to that trial, and then COVID came, and the trial was shut down. So our trial meant that we had to have lots of visits to the hospital. So they all had to stop because they weren't essential. They weren't as part of the primary treatment modality. And then we were also, the exercise routine were being taking place in community gymnasium, and obviously they all closed as well. So overnight, our work package got thrown up in the air, disrupted, and not just for us, but crucially for the patients who were involved. So what did we do? Well, in some ways there's some serendipity, but it's on the back of a lot of hard work. So I mean, I can't take any credit at all for this. This is all down to the professors in my team. I actually just went back clinically into ICU, so it was relatively straightforward for me, having done that for a long time. But our team, so this is Professor Jack and Professor Grocott, came up with a sort of an iteration of WESFIT, and called it SafeFit. And in a sort of post or peri-COVID world, what they decided to do was to move more, rather than being more prescriptive and organising the exercise sessions for people and making the appointments for them, and really steering people directly into the gyms and into the exercises. It was more about supportive self-management. So we all know what the guidance is. We've already talked about that. Not all of us are complying with that guidance. And so what we're trying to do is just to support people and just to take away that, at least that one element of sort of bewildering amounts of information regarding your exercise and your nutrition and your psychological well-being. And this is being done by cancer exercise specialists. So we're working with a charity called Can Rehab. And here's the boss, Professor Anna Campbell, getting her MBE a couple of years ago. And she's got a register of exercise specialists who are all trained personal trainers, but with an additional qualification in exercise training for patients with cancer. So they have a degree of understanding of the treatment modalities, the disease progression, what you can and can't do, etc. We're giving them additional training regarding nutrition. It's nowhere near what Ruth can do, but it's about just trying to conversationally lead the participants to the guidance and make sense of it and answer questions for them and enable them. It's supportive self-management. This is all done remotely via virtual clinics. So it's an online intervention. So you're matched directly with an instructor if you sign up to the trial. There are 23 sessions that we will offer you. They're about an hour per session, and they're delivered over 6 months. They start off as sort of 3 a week, and it goes down to 2 a week, then 1 a week in the last couple of months. It's open to anyone with a diagnosis or a suspected diagnosis of cancer at any stage in your cancer pathway. We're moving away from just looking at the sort of perioperative field into supporting patients in their cancer recovery, during chemotherapy, whatever stage you're at. And importantly, it's really speaking to personalised care. The NHS it's a key component of the NHS long-term plan, personalised care. But it's very difficult, thousands and thousands of patients coming through somewhere like UHS or Bournemouth, where I previously worked, in Poole every year. And very difficult to personalise the care package for each of those. But for relatively low cost, you get 23 sessions with a cancer exercise specialist with additional training in nutrition, some well-being, at least definitely some the ability to signpost to the available services so that you know who to approach if you're struggling. And also to encourage long-term behaviour change. So we don't just want to get fit, get you through the treatment. We want this to lead to long-term behaviour change when you're no longer on the trial 6 months later. We've got a very safety-first approach. Mention anything to your instructor. If they can answer your question easily, they'll answer it straight away. But we also encourage them to feedback to us. Any changes, any treatment changes, any changes in your condition comes back to us. We have a meeting, multidisciplinary meeting with consultants, anaesthetists, myself, Professor Jack, Professor Campbell, and we go through each case individually and come up with a treatment plan. And then at 12 months, you get follow-up questionnaires, and we see whether you're doing better. And really, the key thing for us to highlight is that the outcome from SafeFit. It's not a sort of really scientific outcome. This is a very patient-centered outcome. So we're looking at levels of physical activity and how the patient feels. So these are elements of quality of life. And we think that that encapsulates so much. If the patient is feeling better, it's a sort of surrogate marker for lots of other things might be going better too. So we're looking to recruit 1,100 patients. We've got a year or 2 years to do this. If you are interested in finding out more, or you want to find out more and then sign up, or you just want to sign up, we've got our website. It's up and running now. It's quite easy. It's an NHS hosted website, so it's just safefit.nhs.uk. Recommend you go on there and have a look. There's also a lot of information on the Macmillan website. If you are interested, you can either sign up directly there, or what the trial manager has asked me to stress is the best thing to do as we're getting started is to email. So if you email to this, this here, which has been, this email address has been on all my slides, and I'm sure we can share it with you, then it'll go through to Sam, who'll be able to tell you the next steps. So a bit more testimony from our patients. These are people, so we've already done a sort of, a trial run of the trial, if you like. And it's just, I think it's important always to just put up what the patients think about what we're doing, what the patients have said what we're doing. And I think really these are two really good quotes, because both of them just essentially in different ways report a sense of empowerment. It's, a lot of our patients have said to us, everything seems to be happening to them. And then when they come onto our trials, there's a sense of, actually, there's something I can do. I've done absolutely everything I could to help the outcome. Felt I couldn't have done any more, put myself in the best position beforehand, etc. So, these are really key markers of sort of empowerment. These are supported, well-managed patients. And we hope that the model that we're creating here will be the closest thing that we think we will get to a model which may be appealing to NHS commissioners. So, I have to say, coming from the critical care world, where I also look after patients recovering from intensive care, the cancer world is probably a couple of decades ahead in terms of looking after the survivorship aspect of treatment. Your medical treatment, which has previously been discussed, we hope can be supported by these adjunct therapies, exercise, nutrition, etc. You are ahead of the game in the cancer world, but it's still not commissioned as a service, and that's our ultimate goal. So the more patients we can get through these trials, the better. It only costs a few £100 for these 23 sessions from the exercise therapist. It's about £460 to deliver this, and we think we hope to demonstrate that will represent really good value. And the more patients we get through it, the more chance we've got of achieving that goal. And here's our future goal. COVID safe, perhaps, maybe when the vaccines arrive and so on and so forth. But this is a wellbeing centre already set up in Coventry for patients. So this is patients coming. Anyone who's on a cancer pathway can come and attend this gymnasium. You'll note the absence of lycra. You'll note the hat, the handbags. The casual slacks on the. This is the sort of environment that we hope we can create for those people who may feel that the gyms aren't quite for them. Fingers crossed. So that's our trial. If you want any more information around anything that I've spoken to you about today, there are lots of resources that you can go and look at. All of these: moving medicine, 1U, the physical activity, and there's lots of diet advice on the Macmillan website, and obviously the Eat Well Guide. These are NHS approved websites, and they do talk in language that's accessible to patients. So if you are feeling bewildered by the array of resources, these are really good ones to go and have a look at. And it's not just me doing this, not just my professors. There's a whole load of people behind our programme of work. The Wessex Cancer Alliance, Can Rehab Macmillan, Royal College of Anaesthetists, etc., etc. We're part funded by a national lottery. And the one thing that I've had been forced to tell you is that we won an award earlier this year. So it's the Health Service Journal Value Awards, Cancer Care Initiative of the Year. So other people think it's pretty good too. And I hope anyone who joins will also feel the same. So thank you very much. That's everything. So this is our Twitter account. One of our team, Hannah's very good. She's very good on this. So you can go and follow us and find out what's going on there. And again, there's the email address if you want to speak to Sam and get more information about the trial. And if you've got any questions, I'm very happy to answer them. Thank you.
Andy. Thanks very much. That's really interesting. I've got a question actually as a patient as well. So obviously you're not just recommending exercise surrounding treatment, you're just recommending exercise long term. I know a lot of patients suffer from fatigue, and so will not feel like exercising or think that they don't feel like exercise. I personally feel like exercise helps my energy levels, but what would you say to a patient that doesn't feel like it, and how do you balance that?
So yeah, I mean, we hear that a lot, but I can only just back up what you just said, Joe. There's been studies looking at whether exercise helps with fatigue. So you've got really two issues. So there's cancer-related fatigue, and there's the treatment-related fatigue. It's a very well documented side effect of chemotherapy and radiotherapy as well. And specifically for those two groups of patients, there is an increasing amount of evidence. It's not perfect, but it's good that exercise will improve levels of fatigue, will be energizing. I agree with you entirely. If I'm feeling, tired and can't really be bothered, it's kind of often it's the hardest thing in the world to actually get up off the sofa and get started. But, genuinely never regret it, always feel better. We very much recognize, so if you're matched with if you come onto the trial and you're matched with one of our trainers and you say, look, I'm really exhausted today, that session can be moderated to your levels of energy. So it might just be that you get started, get moving, much more gentle levels of exercise, and see how you feel. And the trainer will take you through that. Or you may need a rest day. There's nothing wrong with that as well. You have to listen to your body, but at the same time, I would say get up and give it a go.
Thank you very much. I'm not sure if anyone else has got any other questions specifically for Andy, but we are moving into our question and answer session now anyway. So you've got the Q&A box at the bottom of your screen, maybe at the top, it depends which device you're on. But if you wanted to ask any questions, now is your time. Can't see any coming in at the moment. So I've got a question for you, Neil. To start everyone off.
Well, the chainsaw stopped in the background, so just for a minute.
So you can hear me too, hopefully. So in the this has been mentioned to me before, and then when I did the Neuroendocrine Cancer UK Q&A session, this came up again. So as neuroendocrine patients, which obviously me and Layla are as well, we are supposed to be at a higher risk of other cancers as well, which I understand. And my question to them, which they didn't really answer, was, so how do we keep on top of that? When we have our regular screening, is that something that's considered, or are they just looking at what they would be expecting to see? And if that's the case, how do we manage that as a whole? Because as younger patients, we're not part of any other screening.
There isn't any specific screening in general for other cancer sites, but you will be subjected to an awful lot of scans compared with most people. And that is a reasonably effective cancer screening mechanism. You are prone to a huge range of other malignancies, including other gastrointestinal tumours and gynecological malignancies and all sorts. So it's a real mixture of increased risk, but for none of them is it a massive increase in risk. So you're not 10 times as likely to get a bowel cancer, but you might be maybe half again as likely as the ordinary population. So I think we see something like a 60 or 70% increase in other malignancies compared with the normal population. So for us, it's just something we have to keep an open mind and consider that if ever there's a change in symptoms, it might be that it's not all neuroendocrine. It might be something else that's driving it. And we've always just got to be prepared to think again and reconsider, because with a chronic disease as neuroendocrine can be, over the course of 15, 20, 30 years, there's going to be a fair old chance you'll get something else. And also, sometimes some of our treatments can increase your risk of getting other diseases as well. You know, if you're having low dose radiation, there is a chance of getting bone marrow disorders. And if you're having hundreds of CT scans, then that also is radiation exposure to you. So we just have to bear all these things in mind and always keep that open mind. But there isn't any specific screening. However, you do have access to a lot more medical people than your average lay person. So there's always somebody to ask a question of. And you do get a lot of scans which have a chance of showing many different things. So I think we do incidentally pick up other malignancies, not that infrequently over the course of a year out of our 1,000+ patients that we're following up. We do pick up a few incidental malignancies each year.
Okay, thank you. We've got some other questions as well. So someone has asked just a general question. My spleen has been removed. Does this make me more vulnerable to COVID? Also, would this immune response, the immune response vaccines, less effective? And another question that's related to that is, will NET patients get any priority for COVID vaccinations?
Okay, so the first one about COVID and splenectomy. Viruses usually don't require the spleen for your immune system to work. So in general terms, having a splenectomy doesn't increase your risk of viral illness. It increases your risk of certain bacterial illnesses, such as pneumonia and certain types of meningitis and things like that. So you should probably have been already immunized against those potential infections. And the COVID-19 is not splenically mediated in terms of your response, to my knowledge. And I'm not sure about the specific vaccines, but the majority of them would again not require a functioning spleen to give you immunity. But I think the specifics of that would have to be determined when you know which ones are available. In terms of, are you going to be prioritized? I think you will get the same as any other cancer patient, depending on your age and what treatment you're actually on, because all these things have an influence. If you're on chemotherapy, then there's going to be a different approach to vaccination and immunization. If you've had a low-grade neuroendocrine tumor 15 years ago and you've not got any metastatic disease, you're not going to get any higher priority than anybody else. So again, it's going to be looked at on a case-by-case basis, I think.
Thank you, Neil. I think those are kind of questions that a lot of people have been thinking about. We haven't got, we've got another Q&A here. Okay.
You've gone very quiet, Joe.
Can you hear me now?
Yeah,
Better.
Okay, so we've got another question here. With my recent diagnosis of NET, I am concerned that my son, who has ulcerative colitis, may be at a greater risk of developing a NET. Are there recognised genetic connections and any screening testing available if appropriate?
So is this going to be one for me again?
So Neil.
Oh, good. Nice to have a tricky one. So the majority of neuroendocrine tumours aren't familial, i.e. they don't run in families, unless you've got MEN, multiple endocrine neoplasia, which is a specific subgroup. And if we thought you were at risk of having that, we would have tested you for it and we would have told you. So if you haven't been told that, you don't have a particular familial risk, as in a kind of 50-50 of passing on to your family. With all tumours, there is just a slight tendency to say, okay, so if your mother had breast cancer, you're slightly more likely to have breast cancer, even if you don't have a family where everybody's had it. And it's the same for neuroendocrine. If you do have a first-degree relative who's had it, there is probably just a slight increased risk that the next generation might have it. Over the years, we have seen neuroendocrine tumours arise in areas of ulcerative colitis and also Crohn's disease. I think the association, though, is weak. I don't think there's a very strong association. And I don't think it's something that your son with ulcerative colitis would need any more specific screening for. Somebody with ulcerative colitis is going to get a lot of colonoscopies anyway, and they're going to get a lot of biopsies. So the bowel will be visualized because they'll be looking out for polyps of any sort. If there's any polyps, they'll be biopsied and it will be taken from there. But there's nothing specific to say you're he's at 5 or 10 times increased risk. Nothing like that at all. There probably is a subtle, small increased risk, but not one that I can readily quantify for you.
Thank you, Neil. I don't know if you can see the chat, Layla, but someone's asking you to introduce.
Yes, Helen. This is Bella, part of the Planets team. She is very demanding indeed. She's telling me she wants her dinner, and she also told me earlier that I got the ball date wrong, so I want to rectify that. It's not the 13th of November, it's actually the 30th of October, so apologies for putting the wrong date on there. Well picked up by Bella, who's whispered in my ear. So this is Bella. Hello. And yes, if you can mark the date as the 30th in your diaries, that would be amazing. 30th of October 2021.
I'm going to go to both.
Yeah, why not?
Hey.
You'll be on your own at the second one, but you'll be fine.
Again.
Quite a few comments on the chat about the Safe Fit trial, so that's great, Andy. Looks like you've got some people interested and wanting to sign up. Not sure if anyone else has got any questions. I can't see any more. If you do think of something afterwards, then we have got the online Facebook group for NET patients. You can email me for details of that if you can't find it. And that is just a little bit of chat between patients, just talking about NET specific stuff, all quite gentle. You're very welcome to join in. You don't have to talk. You can just sort of sit there quietly. But if you've got any questions, you can send them direct to us or discuss on there, and I will make sure that we speak to a CNS or one of the doctors, the relevant doctors, to answer that for you. So I think
I've got an individual comment on the side as well, basically to say we can contact. He's just off now, but he's happy to go over anything with the Bournemouth side that's been discussed on an individual basis. And his number is 07917 720 357. So that's great. I just wanted to say thank you everybody for coming along today, but more importantly, thank you for all the speakers. But most importantly, thank you for Jo, because she set this up and she's been very, very worried about how it was going to go, panicking about the packs, panicking about reception. And from my perspective, and I'm sure from everybody else's perspective, it's been fantastic this morning, just as good as a normal face-to-face conference, if not better. It's all been really, really great. So thank you, Jo, so much, my right-hand girl, my Robin, for organising this, because it's been perfect. I'm sure you'll all agree. So have the speakers. So thank you very much, Jo.
Thanks to everyone. Everyone's been really great at getting involved. I haven't had to chase anyone. Everyone's given up their time really willingly, so that's been amazing. And I think it's run fairly smoothly. I actually found it easier to concentrate, I think, on the talks like this, but I think that's my concentration levels. Someone has just asked what the Facebook group is called. It's just Planet's Net Patient Facebook group. So you can go on our Facebook page and see it, but if you can't find it, just give me a shout and I will send you a link, direct you to it. So I think that's it. I don't see any more questions coming through. So thanks everyone for joining us today. It's really great that so many of you have joined in. I'm really pleased. I hope you've all found it as useful as I have. Okay, so I'm going to end the meeting now. So we'll say goodbye.
Thank you, everyone. Bye.
Thank you, everyone.
Bye. Bye. Thank you.
Bye.